Good evening, everyone. Am I audible and visible to all of you? Please update me in the comment section. Good evening. I hope I'm audible and visible to all of you guys. Yes? Update me in the comment section once so we can start our session. Okay. So we can start now. Okay, so I hope you guys are studying and revising in your last lab. We are just like 12 days away from the exams, and revisions are the key right now. Go through all the PYQs right now. Okay, go through all the PYTs right now. Okay, no need to solve the new questions that can give you a stress right now. Okay, and whatever GTs you have studied, whatever GTs you have given so far, revise them. Okay, so in this session today we are discussing some high topics that have been asked repeatedly in the exams. We cannot cover full pathology in just 2 hours or 2.5 hours, but yes, the topics that have been asked repeatedly in your exams, FMG and NEET-PG exam. So we are going to solve the questions related to those topics. Along with that, we'll go into the deep discussion of those topics. Clear? So what exactly you have to do? You just need to interact. Okay, you just need to interact. You just need to type down the comments, type down the answers, integrate. We can integrate this pathology with the pharmacology, we can integrate with the medicine, we can integrate with the physiology, we can integrate with the microbiology as well. Okay, so what you have to do, keep texting in the chat box, be interactive enough. So let's begin with the first question without any further delay. A 42-year-old chronic alcoholic patient presents with a vomiting and abdominal pain. He had similar episodes in the past, along with a steatorrhea, weight loss, and fatigue. Which of the following types of necrosis is seen in the given clinical condition? Update me your answers in the comment section. What will be your answer for the given clinical scenario? You have an alcoholic patient coming to you with vomiting and abdominal pain. He had similar episodes in the past, along with the steatorrhea, weight loss, and fatigue. Which of the following types of necrosis is seen? So what is the type of necrosis seen in a patient? So let's discuss the whole chapter, necrosis. So what exactly is a necrosis? You already have studied there are the two types of cell injuries. Either the cell injury can be reversible or cell injury can be irreversible. So this necrosis is a which type? So it is a irreversible injury. It is a irreversible injury. Now what exactly happens in a necrosis? Okay, now what happens, what is the main cause of this necrosis? Ischemia. What is ischemia? Lack of a blood supply. So when the lack of a blood supply is going on, what will happen eventually to the particular tissue or the cells? Sir, hypoxia will occur. Jab hypoxia hoga, after the hypoxia, what will happen? There will be a decrease ATP formation. Okay, when the decreased ATP formation or the depletion of the ATP, energy of the cell, energy of the tissues, what will happen? There will be a sodium potassium ATPase pump will stop. Eventually there will be a morphological change, nuclear change, and eventually the cell will die. Okay, then the nuclear change like pyknosis, karyorrhexis, karyolysis, you have studied that. Okay, those all will go with what? Necrosis. Okay, now the clinical case. Now first you have to diagnose the clinical case. Alcoholic patient, vomiting, abdominal pain, fatigue, steatorrhea. It gives a diagnosis of, write down in the comment section, so it gives a diagnosis of a pancreatitis. It gives me a diagnosis of pancreatitis. Now tell me, now let's make this question easy. Now tell me, in pancreatitis, which type of necrosis is seen? Some students are answering right, some a bit wrong. Okay, in pancreatitis, which type of necrosis is seen? Yes, your answer is right. So in pancreatitis, the type of a necrosis is going to be fat necrosis. The type of a necrosis is going to be fat necrosis. Is that clear? Is that clear? So a patient coming to you with the with a pain. Usually the pancreatic patient comes with a pain, abdomen radiating to the back, okay, T10. Then the pain is relieved by bending forward, okay, and then that's pancreatitis you have already studied. But you have, the question is asking clinically, okay, integrated. So what type of necrosis? Or fat necrosis, okay. You've already discussed, you already understood what exactly is a necrosis. Yes, I've already discussed the main reason of this necrosis is ischemia, the lack of blood supply to the particular organ, and due to the lack of blood supply to the particular organ, oxygen nahi chala jata hai, hypoxia ho jata hai, and after the hypoxia what happens? ATP depletion happens and sodium potassium ATPase pump stops, okay. Eventually there are morphological changes, denaturation of the proteins and the hydrolytic enzymes, due to which there are changes in the cell, and eventually the cell dies. Now let's discuss what exactly is a caseous necrosis, what exactly is a fat necrosis, what is liquefactive and coagulative necrosis, okay. So if we talk about the first one, coagulative necrosis, okay, it's a most common type of necrosis. Now my dear students, the question that they will ask, they will not ask you the question that okay, MI में कौन सी necrosis दिखती है, which type of necrosis seen in breast, which type of necrosis seen in omentum. Rather than what they will ask, they will give a clinical case. They will give you a clinical picture of a case and then tell you what exactly is a necrosis seen, okay. Now most common reason for this type of coagulative type of necrosis is due to the hypoxia. The most common reason is hypoxia, and hypoxia occurs due to the lack of blood supply to the particular organ, that is called as ischemia, okay. And this coagulative necrosis, it is seen in all the organs of the body except CNS. It is seen in all the organs of the body except the CNS, and the infarct is triangular pale area. This triangular pale area giving the appearance of a tombstone appearance. कौन सी appearance मिलती है guys? This is called as tombstone appearance. So you will remember from now on, the most common type is going to be coagulative necrosis. Second, you will remember it's seen in all the organs except the CNS. And third question that they can ask, you will remember that this is giving a classical appearance of a tombstone appearance, okay. Examples, for example, it is seen with myocardial infarction. It is seen with myocardial infarction, okay. Followed by that, it is seen with dry gangrene. It is seen with dry gangrene, and it's also seen with Zenker's degeneration. Zenker's degeneration in the typhoid fever or enteric fever. So these are the classical examples. These are the classical examples of a coagulative necrosis. These are classical example of the coagulative necrosis. Remember that in coagulative necrosis, the structure outline is preserved. The structure outline is preserved, okay. The tissue architecture is preserved. In which type of necrosis? Coagulative necrosis. In which type of necrosis? Coagulative necrosis. Let's move to the second one, guys, liquefactive necrosis. Now this liquefactive necrosis, it is associated with, first of all, it's going to be a second most common type of necrosis. It's going to be second most common type of necrosis. We'll go a little bit fast, guys, because this is a revision. This is not the main session, guys. We are just here to revise the main stuff. We are just here how to approach to a particular question, how to diagnose the condition, and then how to mark the correct answer. Is that clear to everyone? Yes? Update me in the comment section. Yes? Clear to everyone? Chalo. Now, sir, liquefactive necrosis. This liquefactive necrosis is associated with the abscess formation. This liquefactive necrosis, it is associated with abscess formation, okay. Therefore it is seen with pyogenic infections in CNS. It's seen with pyogenic infections with CNS, okay. It's also known as qualitative necrosis. It's also known as qualitative necrosis. It's also known as qualitative necrosis. For example, what are the examples of a liquefactive necrosis? First of all, we have brain abscess. It's seen with a brain abscess. It's seen with a brain abscess. It's also seen with wet gangrene. It's also seen with wet gangrene. Remember, if the question mentions dry gangrene, your answer is going to be coagulative necrosis. If the question mentions wet gangrene, your answer is going to be liquefactive necrosis. Your answer is going to be liquefactive necrosis. Now, a subtype of a liquefactive necrosis, is called as fat necrosis. Subtype of liquefactive necrosis is called as fat necrosis, and this fat necrosis is seen with the organs having a lot of fat, increased fat, okay, and also it's seen with the increased lipase. जहाँ पे lipase ज़्यादा होता है, जहाँ पे fat ज़्यादा होता है, what is the type of necrosis you will see? Fat necrosis. For example, this fat necrosis is seen in the breast, it's seen in the omentum, or it's seen in the pancreas. It's seen in the pancreas. What are the classical examples? So it's seen with the breast tissue. It's seen with a breast tissue, it's seen with omentum, or it's seen with acute pancreatitis. It's seen with acute pancreatitis. That's why, what is an investigation of choice of pancreatitis? That's going to be lipase, serum lipase levels. In the beginning, we go with the serum amylase, but once the serum amylase is 3 times more than the normal value, we go with the investigation of choice as serum lipase. Is that clear? So remember, the fat necrosis, it's seen with the organs having increased fat and lipase. So that's about liquefactive and your fat necrosis. Then the next one is going to be your caseous necrosis. Okay, again remember, in case of a liquefactive necrosis, the tissue structure is not preserved. The tissue structure is not preserved, but in case of coagulative, the tissue architecture or the outline structure is preserved, okay. This is a pyogenic infection in the CNS, abscess formation, and the type of necrosis seen in liquefactive necrosis. This type is called as coagulative necrosis, having a tombstone appearance. Coagulative necrosis having a which type of appearance? Having a tombstone appearance, okay. Then the next one is going to be a caseous necrosis, okay. In caseous necrosis, there's a lack of clear tissue architecture. Again, that architecture or the structure outline of the tissue is not preserved. It has a cheese-like appearance of necrotic material. See, you can see in the picture, guys, there is a white cheese-like deposit. In which type of necrosis? That it is a caseous necrosis. It's a caseous necrosis. Examples of the caseous necrosis, yes, that's going to be tuberculosis. The example is going to be a tuberculosis, okay. Followed by that, we can have a syphilis. Followed by that, the example will be syphilis, okay. And one more example we have, that's going to be systemic fungal infections, like systemic fungal infections. What are the systemic fungal infections you will see having a caseous necrosis? Yes, that's going to be histoplasmosis, and coccidomycosis. The type of a necrosis that is seen is a caseous necrosis. Then the most important one, guys, remember this one that they can ask, and they have asked repeatedly in case of NEET PG exams as well. That's going to be your fibrinoid necrosis. What's the type of necrosis? Fibrinoid necrosis. And this fibrinoid necrosis, it is associated with the immune. It's associated with the immune complex disease, okay. Having a which type of hypersensitivity is associated? Type 3 hypersensitivity, okay. Remember that immune complex, this immune complex will damage the endothelial cells. The immune complex will damage the endothelial cells. And this immune complex, when will damage the endothelial cells, there is a fibrin deposition on the biopsy. When you will see the tissue, there is a fibrin deposits over there, and such type of necrosis is called as fibrinoid necrosis. Remember that there it is associated with, so the fibrinoid necrosis, it is associated with the deposition of, it is associated with the deposition of fibrin and fibrinoid material. It is associated with the deposition of fibrin and fibrinoid material. Okay, fibrin and fibrinoid material. Okay, now tell me, what are the classical examples? Yes, MAP, M-A-P, write down in the comment section, what are the classical examples of a patient having a fibrinoid necrosis? What are the conditions you will see the fibrinoid necrosis? Yes, what are the examples? M for? M stands with? Anyone in the comment section? Yes, M stands with malignant hypertension. M stands with malignant hypertension. A is Ashkoff body. Ashkoff body is seen in? Ashkoff bodies. Yes, Ashkoff bodies are seen in which condition? Write down in the comment section. They are seen with rheumatic heart disease. Rheumatic heart disease. And which criteria is there? Jones criteria. Which criteria? Jones criteria. Is that clear? Yes. Then P with polyarteritis nodosa. P is polyarteritis nodosa. Is that clear to everyone? Yes. So fibrinoid necrosis, if we talk about a fibrinoid necrosis, it is seen with malignant hypertension, Ashkoff body and polyarteritis nodosa. Okay, Jones criteria. Very good. Jones criteria with the rheumatic heart disease. Okay, Duke's criteria with Duke's criteria. What will be your answer for the Duke's criteria? Duke's is going to be infective endocarditis. Infective endocarditis. Okay, infective endocarditis. Infective endocarditis. Okay, then Wells criteria, modified Wells criteria, that's going to be pulmonary embolism. Then GERD criteria, G-U-R-D, that's going to be fat embolism. Okay, chalo, remember all these criteria. So that completes our necrosis. Okay, let's have a quick recap. Let's have a quick recap of a necrosis. So it's an irreversible cell injury due to the hypoxia, due to the ischemia, then the hypoxia, ATP depletion occurs, and then what exactly happens? There is a denaturation of proteins. There is a denaturation of proteins and inactivation of a hydrolytic enzymes. Okay, eventually what is happening? Cell chains are happening, nuclear chains are happening, eventually the cell is dying. This is an irreversible injury. Most common type is going to be your coagulative necrosis. Okay, and the coagulative necrosis is seen in all the organs of the body except your CNS. The infarct is a triangular pale area giving a appearance, stone appearance. That's going to be the most important point from this type of necrosis. MI, dry gangrene, Zenker's degeneration in the typhoid and enteric fever is a classical examples of a coagulative necrosis. Then the second one we discuss about a liquefactive necrosis. This liquefactive necrosis is the second most common type of necrosis. It is associated with the abscess formation. So it's seen with the pyogenic infections with the CNS. It's also known as coagulative necrosis. So rather mentioning liquefactive, they can mention coagulative necrosis. It is seen, examples are the brain abscess and wet gangrene. A subtype of liquefactive necrosis is a fat necrosis, which is seen at the places you have more fat and a lipase. So it's seen with the breast tissue, omentum and acute pancreatitis Okay, then we talked about, then again remember tissue structure is not preserved in the liquefactive. Then we discuss about a caseous necrosis, and this caseous necrosis is seen in the tuberculosis or the systemic fungal infections. Okay, and then fibrinoid necrosis, it is associated with the immune complex disease. Okay, there is an immune complex that will damage the endothelial cells, and it is associated with the deposition of fibrin and fibrinoid material. Okay, and the classical examples is MAP, malignant hypertension, Ascough body, and polyarteritis nodosa. They will mention which of the following conditions fibrinoid necrosis is not seen. They will give an option in malignant hyperthermia. Okay, so remember, it's hypertension, not hyperthermia. That is something else due to the succinyl choline and all ryanodine receptors. Okay, that malignant hyperthermia is a different stuff. Okay, now let's move to the apoptosis. Is this much clear, guys? All of you guys in the comment section, necrosis is clear? Necrosis tak clear? Samajh aa gaya? Now any type of a question, okay, the question is not important. What's important is the discussion, the explanation that we are doing. Write down in the comment section, everyone. All clear? Can we move to the apoptosis part? Yes, sir. Chalo. Let's begin with an apoptosis. Speed is okay, or I should slow it down? Okay, good, clear. Now let's talk about an apoptosis in a very short manner. Okay, apoptosis. Now if I talk about apoptosis, it's a programmed cell death. It's a programmed cell death which is controlled by genes. Which is controlled by genes. Okay, apoptosis means a programmed cell death. Okay, controlled by genes. Okay, now we have pro-apoptotic genes. What are the pro-apoptotic genes? That will increase the apoptosis. That will increase the apoptosis. What are the genes? Sir, we have P53. Okay, sir, we have BAX and we have BAC. These are the genes that will increase the apoptosis. That will increase the apoptosis. Then anti-apoptotic genes. Okay, again is the apoptosis. What are the anti-apoptotic genes? Number one, all the L containing genes, BCL2. Okay, then BCLXL, then that's going to be MCL1. Okay, and steroids Okay, then the initiators or the sensors, that's BIM gene, BAD gene, okay, PUMA gene, and NOXA. BIM, BAD, PUMA, NOXA. These are the sensors. Now, so what exactly is the question they asked from the apoptosis? Okay, now we already have studied from your main notes. In apoptosis we have intrinsic pathway and the extrinsic pathway, and you know that this apoptosis, it is controlled by the genes, it's controlled by the caspases. Now what are the caspases involved in the intrinsic pathway, and what are the caspases involved in the extrinsic pathway? Now if I talk about an intrinsic pathway, write down in the comment section, what is a caspase involved in intrinsic pathway, what are the caspase involved in the extrinsic pathway. Okay, then let me know what are the executioner caspases. It's a revision session. Intrinsic pathway, extrinsic pathway, and executioner caspases. Yes, what are the in intrinsic pathway, what are the caspase involved? Yes, in intrinsic pathway very good, it's going to be caspase 9. It's going to be 9, so NINE, 9, I intrinsic. E for extrinsic pathway and E for 8. Yes, caspase 8 and 10. Caspase 8 and 10. Okay, and executioner caspases are the common for intrinsic and extrinsic both. That's going to be caspase 3, 6 and 7. That's going to be caspase 3, 6 and 7. Okay, very good. That's going to be caspase 3, 6 and 7. All are important. These are the all PYQs that have been asked. Now my question to you guys, what is the marker of apoptosis? What is the marker of apoptosis? Yes, marker of apoptosis. Write down in the comment section, marker of apoptosis. Very good. So the marker of apoptosis is going to be, yes, annexin 5. Annexin 5. Okay, annexin 5. Very good, very good. Chalo, is that clear? Is that clear to everyone? NEET PG PYQ was asked which caspase is involved in interleukin 1. Which caspase is involved in the production of interleukin 1? Caspase 1 to interleukin 1. Again a PYQ. I hope you guys are solving the all PYQs. I'm writing caspase 1, interleukin 1. Again this is a PYQ. Caspase 1, interleukin 1. Very good. Chalo, these are the gel electrophoresis image of apoptosis and necrosis. This pattern is called as step ladder pattern, and this pattern is called as smear pattern. Now step ladder pattern is seen in guys necrosis or apoptosis. So that is going to be apoptosis. Step ladder pattern is seen in apoptosis, and the smear pattern is seen in necrosis. Normal saline NS. So necrosis is smear pattern. Necrosis is smear pattern. Okay, and step ladder pattern is seen in apoptosis, and step ladder pattern seen in apoptosis. Is that clear to everyone? Is that clear to everyone? Yes, necrosis and apoptosis. Yes, necrosis and apoptosis is cleared. Okay, now remember guys, intrinsic pathway caspase 9, extrinsic 8 and 10, executioner caspase 3, caspase 6 and caspase 7. Marker is going to be annexin 5. On gel electrophoresis, step ladder pattern for the apoptosis and smear pattern for the necrosis. That completes your necrosis and apoptosis. Let's move to the next question. A 55-year-old woman presents with a progressive shortness of breath and fatigue over the past 3 months. She has a history of rheumatic heart disease. And underwent the mitral valve replacement. You already know the lesion is mitral stenosis in the RHD. Okay, criteria is Jones criteria, है ना? अभी पढ़ा 10 years ago. What is the most likely pathological process underlying the calcification observed in this patient? Now, this is a case of a RHD. You already know there are two types of an calcification, sir. Either the dystrophic calcification or the metastatic calcification. Now, simple question has been asked that what type of calcification is seen in a patient having RHD. RHD में कौन सी calcification दिखती है, and what will be the level of a calcium? So what will be your answers? Write down in the comment section. So you have basically the simple question, guys. RHD, what will be the type of a calcification and calcium levels? Yes, write down in the comment section. Very good, most of you are right. Very good. The type of a calcification that is seen in a RHD, that's going to be dystrophic calcification, and the level of calcium is normal. So it's dystrophic calcification with normal serum calcium levels. It's a dystrophic calcification with the normal serum calcium levels. Okay, now let's discuss the two types of a calcification. Okay, now if I talk about first one, D is dystrophic calcification. D is dystrophic, so it is seen with dead or degenerated tissues. Dead or degenerated tissue. Okay, and if I talk about the serum calcium levels in the dystrophic calcification, remember the serum calcium level, serum calcium is normal. serum calcium level is normal. Okay, and then it's usually localized. It's usually localized. Okay, now what are the examples of dystrophic calcification? Remember, it's associations. Remember the associations, bacho. So it is associated with, first of all, tuberculosis. First of all, tuberculosis. It's associated with rheumatic heart disease. It's associated with rheumatic heart disease. It's associated with atherosclerosis. It's associated with atherosclerosis. It's associated with tumors. Yes, it's associated with tumors. It's associated with myocytes ossificans. Muscle like a bone, so hard due to the calcification. Okay, it's associated with Monkberg sclerosis. It's also associated with the infections like CMV. Infections like CMV or cystomoniasis. Okay, so these are the common ones. So it's associated with the tuberculosis. It is associated with rheumatic heart disease, atherosclerosis, tumors, myocytes ossificans, Monkberg sclerosis, and infections like CMV. And the infections like CMV. Is that clear? Is that clear? That's all about a dystrophic calcification. That's all about a dystrophic calcification. Now, if I talk about a metastatic calcification, remember this metastatic calcification, it is seen in living tissues. It is seen in living tissues. Okay, now tell me the examples of metastatic calcification in the comment section. Tell me the examples of a metastatic calcification. Yes, it's seen in living tissues. Okay, after that, serum calcium is high. Serum calcium is high, so there is hypercalcemia. Okay, so there is a hypercalcemia. Okay, then it's usually diffuse. It's usually diffuse. Okay, so hypercalcemia से मुझे याद आया, there is a one question that has been asked repeatedly from a tumor lysis syndrome. Pathology से ही आएगा, tumor lysis syndrome. Now you already know in tumor lysis syndrome, what is happening to the levels of calcium? Increased or decreased? Tell me in the comment section. In tumor lysis syndrome, what is happening to the levels of calcium? क्या हो जाता है? Hypocalcemia. Yes or no? Yes. So there are classical two signs when a patient is having a hypocalcemia. Tapping on a facial muscles. क्या मिलता है हमें वहाँ पे? Choastic sign, or we have a carpopedal spasm. These two questions again remember. Tumor lysis syndrome से question आएगा. Which of the following signs will be associated? Hypocalcemia होता है and choastic sign or carpopedal spasm. Carpopedal spasm. Again an important question. Now which of the following? Okay, now tell me what about the potassium levels? Hyperkalemia or hypokalemia? What about your potassium levels? Hypokalemia or hyperkalemia? जल्दी से बताओ, hyperkalemia or hypokalemia? From tumor lysis syndrome, this is an important one. Hyperkalemia. So there is all increased. ट्यूमर लाइसिस सिंड्रोम में क्या होता है सर? हाइपरकलीमिया होता है, हाइपरकैल्शियमिया होता है, हाइपरफॉस्फेटीमिया होता है, बट hypocalcemia होता है. So they will write the clinical question from the pathology that which of the following is not seen. So your answer is which of the following is not seen? Hypercalcemia. What is seen? Hypocalcemia. Other things hyper. सारा hypercalcemia. Other things are hyper. You have hyperkalemia, hyperphosphatemia, hyperuricemia, but calcium will be decreased. That is hypocalcemia. Is that clear? And hypocalcemia mein we have two things: chvostic sign and carpopedal spasm. Is that clear to everyone? Yes. Okay. जब भी it's also tumor lysis syndrome after the chemotherapy हो जाता है, और massive cell tumor. Now let's go back. Also write down whatever the extra points that I'm telling. Please write down them in your notes. PDF, I'll be sharing this PDF in the Meduhub channel. Okay, in the group you will get this PDF. Okay, now sir, it is associated with dystrophic calcification. Number one, it's associated with parathyroid adenoma. It is associated with parathyroid adenoma. Associations. It's associated with parathyroid adenoma. Then it's associated with a patient having chronic kidney disease. Increased phosphate, right? Then it associates with a Paget's disease. Very good. It's associated with a Paget's disease. It's associated with sarcoidosis. It's associated with sarcoidosis. Okay, then it's associated with multiple myeloma. It's associated with multiple myeloma. It's associated with aluminum toxicity as well. And also primary hypoparathyroidism. And also primary hypoparathyroidism. Yes, milk alkali syndrome as well. Yes, so these are the associations of metastatic calcification. Remember the main name, guys. D is dead, normal. Okay, dead tissue, dystrophic calcification, normal. Metastatic calcification seen in lung tissues, serum calcium is high. Okay, then remember these associations. Is that clear? Dystrophic calcification and metastatic calcification. Yes, clear to everyone? Chalo. Next, let's move to the next topic. In papillary carcinoma, thyroid, all are true except. In papillary cancer thyroid, all are true except. Now tell me, what will be the answer? The risk of radiation, 98% having a good prognosis. It's seen in young individuals around 20 to 40 years of age, and it's associated with calcitonin. Okay, again, very good. What is the answer, guys? Yes sir, the answer is going to be associated with calcitonin. You already know that calcitonin associated tumor from the thyroid is going to be your medullary thyroid carcinoma. Okay, yes, it is having a history of radiation exposure. It's having a good prognosis. It's seen in a young individuals in 20s. That's going to be your papillary carcinoma of thyroid. Okay, this is your PYQ. Now let's discuss about a papillary thyroid carcinoma. Okay, now remember guys, it's the most common type of thyroid cancer. Point number one. Second, it's seen in young patients. What is the age of the patients? Around 20 to 40. Okay, third one, guys, it is associated with, sir, this is associated, it is associated with history of radiation exposure. History of radiation exposure. It is associated with a history of radiation exposure. Okay, now any one of you, can you tell me what is the gene associated? What is the gene associated? What is the gene associated with papillary carcinoma of thyroid? Yes, it's going to be BRAF. okay, followed by ret. But your one answer is going to be PRAF. Is that clear to everyone? Is that clear to everyone? Then the papillary thyroid cancer, there are increased chances of the lymph node involvement. So a patient will have a cervical lymphadenopathy as well. And the spread of the cancer is lymphatic spread. So let's write more 2 points. Okay, there are increased chances of lymph node involvement. There are increased chances of lymph node involvement. We can have a cervical lymphadenopathy. Cervical lymphadenopathy, and the spread that is seen, lymphatic spread. Lymphatic spread. Okay, is that clear? Now if I talk about the nuclear chains in a papillary carcinoma of a thyroid, you already know this empty looking appearance of the nuclei. You can see the empty looking appearance of the nuclei. What are these nucleus called as? So they are called as orphan annii nuclei. They are called as orphan annii nuclei. So the empty looking appearance of this nuclei, orphan annii nuclei. And we have a bodies, and we have a bodies seen. What are these bodies? Sarkari bodies. They are found repeatedly as samoma bodies, made up of calcium. Samoma bodies, and these samoma bodies, it's also seen in samoma bodies are also seen. Yes, they are seen in meningioma, they are seen in serous cyst adenoma, they are seen in also mesothelioma, and also seen in which condition? Papillary thyroid carcinoma. Also seen in papillary thyroid carcinoma. Is that clear? So that was all about your papillary thyroid carcinoma. That was all about papillary thyroid carcinoma. Is that clear? Chalo, next. Next. Now, which of the following mutations may be found in a patient with follicular carcinoma? Which of the following mutations will be seen with a patient having a follicular carcinoma? Which of the following mutations may be found in a patient with follicular carcinoma? Write down in the comment section. Yes, samoma bodies, PSM2, papillary thyroid cancer. Yes, serous cyst adenoma, mesothelioma, meningioma. Now tell me guys, which of the following mutations will be seen with a patient having a follicular carcinoma? Follicular carcinoma, what will be your answer? Chalo, let's discuss about a follicular carcinoma. Okay, yes, very right, it is a RAS mutation. Very good, it's a RAS mutation. Now let's discuss about BRAF. We already discussed a BRAF with what? BRAF with the papillary thyroid carcinoma. Okay, now let's discuss about a follicular thyroid cancer. Thyroid cancers are very, very important from a medicine point of view as well as a pathological point of view. Okay, now it's a second most common type of cancer. It's the second most common type of thyroid cancer. Okay, it's seen in patients. It's seen in patients age 40 to 50 years. It's seen with the patients having aged 40 to 50 years. Okay, the risk factor, increased risk with iodine deficiency, increased risk with iodine deficiency, iodine deficiency, or long standing goiter. Or long standing goiter. Okay, now in follicular thyroid cancer, the gene associated is, sir, what is the gene associated? That's going to be which mutation? RAS mutation. Which gene is associated? RAS. Okay, followed by that, remember they will ask you one more question, that out of which of the following cancers, the FNAC is not useful. So remember, FNAC is not useful. FNAC is not useful in case of a follicular carcinoma of thyroid. Why? Because it cannot differentiate between a follicular adenoma and follicular carcinoma. That's why the best choice over there is going to be your biopsy. Okay, that's why the best choice for is biopsy. Okay, so FNAC is not useful because it cannot differentiate between follicular adenoma and follicular carcinoma. That's why we are going for the biopsy. Okay, and the spread in case of follicular carcinoma is going to be which spread, bacho? Hematogenous spread. It's going to be hematogenous spread to bones. Is that clear? Hematogenous spread with bones. And now we have these follicles. filled with the colloid. What are the cells called as? So the cells that are seen is called as Hurley cells. These follicles filled with colloid, what are these cells called as? They are called as Hurley cells. Okay, and remember, if more than 50% or if more than 50% Hurley cells are there, then we have a poor prognosis. More than 50% is poor prognosis. Now, two questions that I asked from this particular slide. One is going to be your gene, second is going to be FNAC is not useful. But if they give a clinical question mentioning that Hurley cells are seen, then your answer is going to be yes, follicular thyroid carcinoma. Then your answer is going to be follicular thyroid carcinoma. Is that clear to everyone? Yes. Marker, sir, marker for this is going to be serum thyroglobulin. Very good. Marker is going to be serum thyroglobulin. Marker is going to be serum thyroglobulin. Yes, Hashimoto's. Most common cause of hypothyroidism is going to be Hashimoto's thyroiditis. Okay, and what are the antibodies seen? Write down in the comment section. Yes, very good, Robin. This is the same thing. Now tell me, what are the antibodies seen in Hashimoto's? Hashimoto's, the examiner will give the antibodies, mark the diagnosis. Hypothyroidism, TSH will be increased. So what will be the antibodies seen in Hashimoto's? TPO. Very good. That's going to be TPO. Let's move to the next question, guys. A 45-year-old female, anti-TPO. Very good. A 45-year-old female presents with a thyroid nodule and elevated calcitonin levels. The biopsy confirms the medullary thyroid cancer. Which cells are the origin of this cancer? Now a patient is coming to you. It's a diagnosis of a medullary thyroid cancer, as a patient is already having an increased calcitonin levels. In the first question, we have already discussed that increased calcitonin levels is a diagnosis of medullary thyroid cancer. Now tell me, what is the origin of this cancer? Which cells? Is it follicular cells, parafollicular cells, lymphocytes, or chief cells? Yes, very good. You already know this. The answer is going to be parafollicular C cells. The answer is going to be B, parafollicular C cells. Sir, what about follicular cells? These follicular cells, they produce thyroid hormones. T3 and T4. Okay, they produce hormones T3 and T4. So parafollicular cells, they store and produce calcitonin. They store and produce calcitonin. If I talk about lymphocytes, if there is a lymphocyte, these are the immune cells, and if there is a lymphocytic infiltration, that's going to be your Hashimoto's thyroiditis. Agar question mein diya hai lymphocytic infiltration, okay, Hashimoto's thyroiditis. And these are the chief cells. Chief cells are found in parathyroid gland, and they will produce parathyroid hormone. So they produce parathyroid hormone. Is that clear? So what are the cells? What is the origin of a medullary thyroid cancer? That's going to be your So that's going to be parafollicular C cells. Again, number one question. Number second has been asked, calcitonin levels. Okay, very basics questions. Okay, but the easier it seems, at the time of examination the story is entirely different. Okay, at the time of examination story is entirely different. Nervousness, anxiety, okay, time management, lot of things. Chalo, next question. Now let's discuss about a medullary thyroid cancer. Now everything you know about a medullary thyroid cancer, write down in the comment section. First of all, sir, the origin. First of all, the origin. It's arising from parafollicular C cells, because these parafollicular C cells are the cells that will store and produce calcitonin. Okay, number second question, guys. It is associated with MEN2 syndrome. Very important. It is associated with MEN2 syndrome, mainly MEN2B followed by MEN2A. Okay, then on histopathological examination, very important points. Okay, on histopathological examination we will see there is an amyloid rich stroma. There is an amyloid rich stroma. Okay, and that's why if the question mentions which of the following thyroid cancer has amyloidosis seen, amyloidosis is seen with which type of thyroid cancer, your answer is going to be medullary thyroid cancer. Whenever a clinical case will mention amyloid, your diagnosis should go with what? Medullary thyroid cancer. Now tell me, which type of cardiomyopathy will be associated with the amyloidosis? Which type of cardiomyopathy will be associated with the amyloidosis? Thyroid mein is medullary thyroid cancer, and in cardiomyopathy, tell me faster. जल्दी जल्दी बताओ. Which type of cardiomyopathy is having a amyloidosis? Restrictive. Very good, excellent. It's seen with the restrictive, very good. Remember, athlete, young patient, okay, myosin chain defect, that's going to be HOCM. Diagnosis, HOCM. Propranolol is a drug of choice. Second one, a patient if alcoholic में क्या दिखेगी? DCM, dilated cardiomyopathy, alcoholic. Okay, amyloidosis goes with the restrictive cardiomyopathy. Stress or broken heart syndrome, Takayatsubo cardiomyopathy. Is that clear to everyone? Young athlete, okay, young or athlete, you go with the HOCM. Drug of choice is beta blockers, propranolol. Banana shaped hypertrophy is seen, है ना, and myosin chain defect, है ना, alpha myosin chain defect is seen, HOCM. Amyloidosis क्या मारोगे? Restrictive cardiomyopathy. Dilated is seen, alcoholics. I'm just telling a small hints. And then stress, if there is a stress heartbreak syndrome, that's going to be Takayatsubo cardiomyopathy. In case of a thyroid cancers, which cancer is having amyloidosis? That's going to be a medullary thyroid cancer. Clear it out? Is that clear to everyone? Yes. Now tell me, if I talk about amyloidosis, if a patient is having a hemodialysis, kidneys, which type? What is the biochemical type in the kidneys? Chalo, I will write it here. A beta 2. Kidneys, that's going to be hemodialysis. Okay, sir. Next one. Can you tell me about cardiac? The cardiac? Which type of biochemical type? Cardiac, A beta 2 with kidney, मैंने लिख दिया. Cardiac is, बता दो cardiac का, बता दो multiple myeloma का. These three comes. Okay, A beta 2, very good. So A beta 2 is going to be kidneys. Yes. Okay, tuberculosis, IBDs, cancers, that is AA. Very good. AL is going to be multiple myeloma. Very good. And cardiac mein? What about the cardiac? Cardiac is going to be ATTR. Cardiac is going to be ATTR. Is that clear? Cardiac is going to be ATTR. Chalo. ATTR, yes, hereditary polyneuropathies में भी दिखता है, but cardiac में remember. Okay, amyloidosis. Okay, and what is the stain for amyloid? Congo red stain, है ना? Congo red stain. Again a PYQ. Number second part, yes. और भी कुछ हमें देखने को मिलता है under the polarized microscopy. Apple green bifringence. Apple green bifringence. Is that clear to everyone? ठीक है ना? Is that clear to everyone? So this is going to be your apple green bifringence. Okay, under the polarized microscopy. Chalo, this one is going to be AL in multiple myeloma. Okay, A beta 2 with the hemodialysis mediated, and ATTR with the cardiac, senile cardiac localized amyloidosis. These are the important ones. Chalo, let's get back to the question. Now I mentioned that amyloid rich stroma, that means the amyloidosis is seen with the medullary thyroid carcinoma, and in case of a cardiomyopathy it was restrictive cardiomyopathy. It was restricted cardiomyopathy. Okay, now if I talk about the marker that has been asked multiple times, so the marker is calcitonin. The marker is calcitonin, and if calcitonin is negative, what will be the marker? Write down in the comment sections. If calcitonin is negative, this is an important question bacho. If calcitonin is negative, then the marker is going to be CEA. Then the marker is going to be CEA. The marker is going to be CEA. So if we talk about the gene associated, with the medullary thyroid cancer, anyone in the comment section? Yes, the gene associated is a RET gene. कौन सा gene associated है? RET gene. Okay, so you already remember RAS with follicular carcinoma of thyroid, BRAF with a papillary thyroid cancer, and RET gene is going to be medullary thyroid cancer. Remember, the marker is going to be calcitonin, and amyloidosis is seen with the medullary thyroid cancer, and these are the parafollicular C cells. Okay, from which the medullary thyroid cancer is a marker. Okay, marker for medullary thyroid cancer is what? Calcitonin. Okay, and these parafollicular C cells is what store your calcitonin and produce calcitonin. Okay, the colloid in the follicular lumen. Chalo, is that clear? Now last one is going to be anaplastic thyroid cancer. Remember guys, it's the least common. It's going to be least common. Okay, it's seen in an old age group, usually 5th to 7th decade. Then the risk factor for this is going to be a P53 mutation. Risk factor is going to be P53 mutation, and clinical features, and the clinical features of this condition: patient will have a rapidly enlarged swelling. There is rapidly enlarged swelling. There is a hoarseness of voice due to the RLN involved, and due to the compression of a trachea there is a stridor. So right, there is a hoarseness of voice because of recurrent laryngeal nerve involved, and there is a stridor due to the tracheal compression. Is that okay? And mainly the metastasis of this cancer goes to the lungs. You can see very rapidly enlarged swelling, and that's why it involves the recurrent laryngeal nerve, and yes, it is going to have a worst prognosis, having a worse prognosis. So that completes your thyroid cancers. Is that clear to everyone? So all the thyroid cancers are cleared. Is that okay? Now let's have a quick revision of these thyroid cancers, okay, then move to the next chapter. Okay, now let's have a quick recap. First of all, we discussed about a papillary thyroid cancer. So it's a most common type of a thyroid cancer. It's a most common type of a thyroid cancer. It's seen in a young patients having age around 20 to 40. It's associated with a radiation exposure. Okay, it's associated with a radiation exposure. The gene associated is BRAF. Okay, and it is having a lymphatic spread. It's having a lymphatic spread. Okay, and if they ask from a pathological slides, we have a classical empty nuclear cells, an empty nuclei looking appearance, having a name orphan ani nuclei, and we have a samoma bodies. We have which bodies? Samoma bodies. Followed by that, we discuss that follicular cancer carcinoma, what will be the mutation seen? That's going to be a RAS mutation. So follicular is the second most common type. Yes, it is seen with the patient's age around 40 to 50 years. It's increased with the iodine deficiency or the long-standing goiter. The marker is serum thyroglobulin. Hurley cells are seen, and the gene is going to be RAS. Okay, FNAC is not useful. Please remember that, because it cannot differentiate between a follicular adenoma and follicular carcinoma. That's why the investigation we are going is going to be biopsy, and the spread is a hematogenous spread. Followed by that, we discuss about a medullary thyroid carcinoma, that the origin of this medullary thyroid carcinoma is going to be parafollicular C cells. Followed by that, it is associated with a MEN2 syndrome. Okay, and amyloidosis is seen with the medullary thyroid carcinoma. The marker is going to be your calcitonin. The marker is going to be the calcitonin. And remember, if calcitonin is negative, then you can go for CEA. The gene associated is going to be a RET gene. Followed by that, the least common one having a worst prognosis is your anaplastic thyroid carcinoma. Okay, it is seen with the age 5th to 7th decade. Risk factor is a P53 mutation, and it's a rapidly enlarged swelling having a clinical features of hoarseness of voice due to the recurrent laryngeal nerve involvement, and patient can complain of a stridor due to the tracheal compression. That completes your thyroid cancers. Is that clear to everyone? Is that clear to everyone? Yes? Comment section? Yes, sir. Now let's move to the intracellular pigmentations. Okay, now identify the pigment shown in an histologic section from a heart in an aged person died at the age of 37. So what will be the answer? What is the intracellular pigment seen in an image? You can see, guys, there is a yellow brown pigment. What is this intracellular pigment after the lipid peroxidation? What is this pigment called as? Yes, what is the answer, bacho? What will be the answer? Very good. So the pigment seen in the picture, it's a lipofuscin, yellow brown pigment. It's a lipofuscin. This pigment, it's also called as, what is the another name for this pigment? It's also called as wear and tear pigment. It's also called as wear and tear pigment, or it's called as pigment of aging, Okay, now let's understand all the pigmentations, all the important intracellular pigmentations and their location. So first of all, guys, lipofuscin, remember, it's what we will see in the lipofuscin, you will see yellow brown pigment. So it's a yellow brown pigment derived from lipid peroxidation. Oxidations of lipids, and the cell is going to the different chains. You have intracellular pigmentation accumulation, and this accumulation is called as lipofuscin. Is that clear? So this is also called as, it's also called as wear and tear pigment. They can mention this line, okay, or it's called as pigment of aging. It's called as pigment of aging. Okay, next one, it's there is a perinuclear perinuclear intralysosomal pigment. Intralysosomal pigment, and it's common in aging cells. It's common in aging cells. What are the aging cells, sir? It's common in liver and heart. Liver and heart. So yellow brown pigment, that's going to be lipofuscin. Very good. Next one, fast. So melanin. Okay, melanin is derived from which amino acid? Jaldi batao. Melanin is derived from which amino acid? Fast. Melanin is derived from which amino acid? Yes, don't confuse. Very good, sir. It's derived from T से आता है tyrosine. Very good. It's a tyrosine derived pigment. It's a tyrosine derived pigment. Okay, now this tyrosine derived pigment, remember that it's a dark black or brown pigment. Dark black brown pigment. Okay, and this pigment, it's responsible for the color of the skin, right? Yes, sir. So if this pigment is absent, what is the condition? If the pigment is absent, if this melanin is absent, what will be the condition? The patient is having albinism. Yes, I know patient is having albinism, right? The examiner asked the question, which of the following enzyme will be deficient in a patient having albinism? Tell me the answer in the comment section. What is the enzyme that is deficient in a patient having albinism? This was your PYQ. What is the enzyme deficient in a patient having albinism? Now you know that it comes from which amino acid? Tyrosine. Tyrosine से हमारा epinephrine, non-epinephrine आता है, melanin आता है, T3, T4 आता है. So what will be the enzyme deficient? What will be the enzyme deficient? They will mention tyrosine kinase, tyrosine hydroxylase, tyrosinase. I'm giving you option: tyrosinase, hydroxylase, tyrosine kinase. Write down the answer. Yes, the enzyme deficient in case of an albinism is, in case of albinism, we usually mark the mistake because they all start with what? Tyrosine. So it's going to be tyrosinase, simple tyrosinase. Okay, it's going to be simple tyrosinase. No tyrosine kinase, hydroxylase, wo nahi marna. Is that clear? Tyrosinase. Followed by that, now this pigment is responsible for color of skin and hair and eyes. Responsible for eyes. Okay, and remember this melanin, it protects against the UV radiation. It protects against the UV radiation. Okay, and tell me, what is a stain that is used? What is the stain that is used for melanin? Very good, that's going to be Masson-Fontana stain. Sir, this is all Masson-Fontana stain. Okay, general path, simple questions will be asked, guys. Every single thing is important. So rather discussing melanin, we also discussed the albinism, integrated it with the dermat, then the stains also cleared. Masson-Fontana stain. Okay, then a hemosiderin, it's an iron derived pigment. fast, these are the easy ones, so let's go a bit fast. This is a iron, this is your iron derived pigment. Okay, and then it's a golden brown pigment. It's a golden brown pigment, accumulates in a chronic overload, iron overload, in chronic iron overload. Okay, and remember what are the conditions? We can have a thalassemia, okay, or a patient having a multiple blood transfusion, or a patient having a chronic hemolytic anemia, or a patient having chronic hemolytic anemia. Okay, remember the name of the stain. Can you tell me the name of the stain in comment section, please? What is the name of the stain for hemosiderin, for the iron? Yes, the name of the stain is, faster, that's going to be, yes, Prussian blue stain. And we have a reaction, क्या बोलते हैं उस reaction को? Pearl's reaction. Okay, we cannot go much deeper, so this much is enough. This is going to be your hemosiderin, Pearl's blue reaction, having a Pearl's blue stain. This black pigment, Masson-Fontana stain, having a melanin albinism is the answer, and the deficient enzyme is tyrosinase. Okay, and this yellow golden pigmentation in the liver cells or the heart cells is called as a lipofuscin, wear and tear pigment. Okay, now these three, and we are done with this. Now what is amyloid? We already know it's an extra proteinaceous deposit. Extra proteinaceous deposits. Okay, now tell me, my dear students, what exactly is accumulated in amyloid? Write it down. There is an accumulation of misfolded proteins. So there is accumulation of misfolded proteins, and the stain for amyloid, remember the stain, they can ask that the stain is Congo red stain. The stain is Congo red stain, and this picture under the polarized microscopy, what is an appearance called as? Under the polarized microscopy, we have apple green bifringence. Apple green bifringence. Then the anthracosis. Now all these pigments, whether it was lipofuscin, whether it was melanin, hemosiderin, or amyloid, it is endogenous pigments. They are inside when the cells are reacting in the inside. Okay, lipid peroxidation is happening, free radical injury is happening, there is an accumulation of these enzymes. Okay, accumulation of these pigments. All these are questions if they ask from heart and liver cells, wear and tear pigment, that's going to be your lipofuscin. Pathology mein agar ye dikhayenge with a Masson-Fontana stain, a black color, that's going to be your melanin, tyrosine derivate. Remember the albinism from there. If they will show you a iron related chronic iron overload, they will give a history of a patient having a multiple blood transfusion, patient having a thalassemia, patient having a toxicity. Okay, so you will remember that this is a hemosiderin, Prussian blue stain, and the Pearl's reaction. Amyloid ka case diya hai, you will remember the Congo red stain and under the polarized microscopy, and these are all endogenous. Now if I talk about most common anthracotic pigment, or the question is exogenous pigment, bahar se, that is going to be your most common exogenous pigment. From outside, that's going to be your anthracosis. That's going to be your anthracosis. So most common exogenous pigment. Now what is the reason? There is an accumulation. So there is an accumulation of carbon particles, due to which on the lungs you is also called as, kya lung ho jata hai lungs mein? They are also called as black lung. Black lung, is that clear? Black lung, you can see this anthracotic pigment. Anthracotic pigment. That's why these patients have which type of pneumoconiosis? Anthracosis bhi milta hai. Yes, in coal workers, anthracosis, is that clear? And if that anthracosis, remember that if that anthracosis plus if there is a rheumatoid arthritis, there is a classical syndrome called as, what is the name of the syndrome? Sir, it's called as Kaplan syndrome. Sir, it's called as Kaplan syndrome. Now you know that rheumatoid arthritis is there, and this anthracosis, it's a type of a pneumoconiosis. Now it is also called as this Kaplan syndrome. It's also called as rheumatopneumoconiosis. What is the name of this Kaplan syndrome? It's also called as rheumatopneumoconiosis. Is that clear? Rheumatopneumoconiosis. Now remember, the anthracosis, it's a most common exogenous pigment. All other are endogenous pigments. It is due to the accumulation of the carbon particles, and this anthracosis, sir, it is common in smokers. It is common in smokers. Now the last one is going to be your glycogen accumulation. Okay, write it down. It's a granular pink staining material. It is usually seen with glycogen storage disorder. So let's write, it's a granular pink staining. Let's go a bit fast in these stains from a general path because you have revised it multiple times, but yes, we cannot skip some important PYQs. Staining materials that represents stored glucose, that will represent the stored glucose. Okay, and it usually accumulates in liver and muscles. Okay, and it's increased in glycogen storage disease. And can any one of you tell me what is the name of the stain? What is the name of stain? What is the name of stain for glycogen? Yes, it's a PAS stain, periodic acid Schiff. It is PAS stain positive. It's going to be PAS stain positive. So that completes our intracellular pigmentations. Is that clear to everyone? Yes, is that clear to everyone? Let me ask some rapid fire questions in the comment section. Yes, will you answer, guys, fast? Let me ask you all the questions that we have studied from last 1 hour. Chalo. Now tell me, my dear students, what is the type of the mutation? What is the name of the mutation seen in a papillary thyroid cancer? What is the name of the mutation seen in papillary thyroid cancer? Question number 1. Fast. Papillary thyroid cancer. What is the name of the mutation? BRAF. Faster. That's going to be BRAF. Okay. What is the name of the mutation in medullary thyroid carcinoma? Medullary thyroid carcinoma. Faster. That's going to be RET. That's going to be RET, R-E-T, medullary thyroid carcinoma. Okay, P53 will be anaplastic. Okay, and follicular ke saath, which one will be with the follicular? That's going to be RAS. With follicular cancer. Okay, then we discuss about a necrosis. We've already revised that. Now let's move to the very important questions, very important chapter. That's going to be your vasculitis, jahan se question aata hai. Okay, chalo. Next question. A female 70 years old came to the hospital with a fever, headache and jaw pain. So she's having a fever, headache and jaw pain intense along the course of superficial temporal artery. What is the most likely diagnosis? What is your most likely diagnosis? So you have a female, my dear students, 70 years, she's having fever, headache, jaw pain and superficial temporal artery is involved. You have seen. What is the likely diagnosis? So many hints. So what is your answer, bacho? What is your answer? Yes, sir. The answer is going to be very good. The answer is going to be giant cell arteritis. The answer is going to be giant cell arteritis. Now, what exactly is this thromboangiitis obliterans? What is polyarteritis nodosa? What is Wegener's granulomatosis? All the questions that have been asked from these particular 4 options, these particular 4 topics, let's discuss all of them. Okay. Now, sir, we already know the vasculites. We have large cell, we have medium, and we have small vessel. Large vessel, medium, and small vessels. This large vessel vasculitis, it affects mainly aorta or its major branches. Aorta or its major branches. Okay, so it affects aorta or its major branches. Is that clear? Then if we talk about this giant cell arteritis, this giant cell arteritis, it's also called as temporal arteritis, or temporal arteritis is also called as a giant cell arteritis. So it's also called as giant cell arteritis. It's the most common vasculitis in a patient It's the most common vasculitis in a patient more than 50 years. It's the most common vasculitis seen in a patient more than how many years? 50 years. Can any one of you tell me what is the artery involved? Sir, the artery involved is superficial temporal artery. Superficial temporal artery is involved. Can you tell me the superficial temporal artery is a branch of? Anyone in the comment section? Superficial temporal artery is the branch of which artery? Bata do. It's a branch of the which artery? Comment section. So that's going to be the branch of external carotid artery. That's going to be a branch of external carotid artery. ठीक है ना? That's going to be the branch. Very good. Rituraj, external carotid artery. लिखता हूँ मैं यहाँ पे ECA. ECA means external carotid artery. Now, what are the clinical features? Now, the question that they can ask, the most common if they ask, let me write like headache. Headache is going to be some most common. Okay. If they ask more specific, that's going to be jaw claudication. That's going to be jaw claudication. Most specific is going to be jaw claudication. Then patient is having a pain in shoulder and pelvis. Patient is having a pain in shoulder and pelvis. That is called as polymyalgia rheumatica. What is polymyalgia rheumatica, sir? Pain in shoulder and pelvis. Okay. Followed by that, patient will have a fever. Patient will have malaise. And due to the involvement or due to the decreased blood supply to the eye, patient can have a sudden onset blindness. Sudden onset blindness. Is that clear? Is that clear? Now it is all about what? Temporal arteritis. Now you can see, guys, temporal arteritis. This picture of an old woman can be seen. Okay. And now what happens in the vasculites? Most of them, the lumen is narrowed. Are you getting my point? Now see, guys, this is a normal temporal artery and this is a temporal arteritis. The lumen is decreased. So when the blood flow is decreased to a particular organ, what will happen? Now if a eye blood flow come hota hai, so what is happening? Sudden onset blindness. Okay. Now, sir, how to diagnose? Okay, how to diagnose this? You will see there is an increased TLC counts. Patient will have increased ESR, as well as there will be decreased hemoglobin or decreased hematocrit. Decrease hematocrit. Okay. If we take the biopsy of a patient from the temporal artery biopsy, we'll see there is a presence of granuloma. We'll see there is a presence of granuloma. There is a presence of granuloma. And if we talk about on the biopsy, what is a characteristic feature? There is internal elastic lamina fragmentation. internal elastic lamina fragmentation. I've already attached a picture of a biopsy. Now see, my dear students, the lumen is exactly decreased. Okay, so there is a reduction in a lumen size. Along with that, there is a fragmented elastic lamina and a giant cell granuloma is seen. And I've already told you what is the classical name of the stain that is used for this. Anyone in the comment section, please? Even though they will not ask, can any one of you tell me what is the name of the stain? The name of the stain is Van Giesen stain or Giesen stain. Is that clear? So a patient old age, 70-year-old, fever, headache, jaw pain and superficial temporal artery is involved, your answer goes to giant cell arteritis or temporal arteritis. Remember one thing, remember if they mention jaw claudication, diagnosis temporal arteritis, ठीक है ना? Because different types of claudication we are coming up with. The intermittent claudication is seen in which type of vasculitis? Okay, jaw claudication. Remember, patient will have an headache. Along with that, patient will have a pain in the shoulders and pelvis, polymyalgia rheumatica and sudden onset blindness. Is that clear? And this fragmented elastic lamina is seen on the biopsy and the granuloma as well, and the stain is VGS stain. Is that clear? And you will see there is a reduction in the lumen size. Now what will be the treatment? Sir, I will start with IV steroids. And alternative to the IV steroids, it's a drug which was also used, tocilizumab. It's also used in multiple myeloma. It was also used in COVID as well. Now can you tell me that which interleukin inhibits this drug? This drug inhibits which interleukin? Pharmacology question. Which interleukin is inhibited by this drug? Tocilizumab, sarilumab, tocilizumab. Very good. This drug was used in a COVID patients at the time of a cytokine storm. So the classical drug, it inhibits interleukin 6. It inhibits your interleukin 6. So tocilizumab is an alternative treatment for the what? Temporal arteritis or giant cell arteritis. Okay, now sir, why exactly this lumen is reduced? It is because of collection of macrophages and helper T cell. Collection of macrophages and helper T cells or T cells. Now that's why how granuloma is formed. Okay, that's how a granuloma is formed. Okay, you might have studied in your main notes of a pathology, when there is a collection of these macrophages, T cells and other neutrons and all, eventually they form a granuloma. Eventually क्या बन जाता है? Granuloma. Look at the picture. This is a picture from the main notes. Let me show you. Okay, see, activated macrophages are responsible for the formation of epithelioid cell, and there is a central area of inflammation which is surrounded by the macrophage, lymphocytes and the plasma cells, which is called as granuloma. So these macrophage, T cells, epithelioid cells, they all combine and give rise to the granuloma. Is that clear? Chalo, that's all about temporal arteritis. That's all about your temporal arteritis. Okay, can we move to the next part? Bacho? Yes. Okay, next question. A 35-year-old female presents with a claudication in forearm. She presents with a claudication in the forearm, transient loss of vision, again transient loss of vision and an abdominal pain. She also had the weak femoral pulse. The femoral pulse was weak. Fundus showed a retinal hemorrhage. She's having a hemorrhage in ophthalmic vessels. What is the most probable diagnosis? So a very one hint is given in the question, guys. Normal hint is given. Catch the hint. Patient is having weak pulse, and which disease is called as pulseless disease as well? Weak pulse. Your answer is A. How come polyarteritis nodosa? No. transient loss of vision, abdominal pain. She also had a weak femoral pulse. Okay, so pulseless conditions, we go with the Takayasu arthritis. Is that clear? Now what exactly is this Takayasu arthritis? Let's understand a fast. So this Takayasu arthritis, it's also known as aortic arch syndrome, because it involves all the branches of the aortic arch, say. Okay, or it's also called as pulseless disease. Very good. Now most common involvement of which artery? That's your subclavian artery. So that's a subclavian artery. Okay, and it is seen with the patients, age less than 50 years. It's seen with the patients, females, usually less than 50 years. Now what are the clinical features of this? Remember the main clinical features. Okay, now examiner can give any of the clinical features. Now the normal ones is going to be patient will have a fever. Okay, patient will have headache, patient will have myalgia, patient can have a syncope, and patient will complain of a weak pulse. Now my dear students, if coronary arteries are involved, patient क्या symptoms देगा main? So patient will have angina, or patient can have MI, myocardial infarction. If coronary arteries are involved, patient can have a myocardial infarction. Next, bachcho, if the renal arteries are involved, okay, what will happen? There will be an activation of a renin angiotensin aldosterone system. There will be an activation of RAS. Renal arteries involved होगी. When there is a activation of RAS, patient को क्या होगा? Renovascular hypertension. Most common cause in adults renovascular hypertension in India is going to be your Takayasu arthritis. Renovascular hypertension. So BP is unequal in both hands. Coarctation of aorta COA unequal. Upper limbs, navel arms. अगर दोनों में होगा तो Takayasu. Okay, upper and lower limbs coarctation of aorta, unequal BP. ठीक है ना? चलो. Visual disturbances due to the ICA involvement, intracerebral artery involvement, patient will have. That's why it is mentioned that a patient is having what? Vision loss, visual disturbances. Okay, and this Takayasu arthritis, my dear student, it's having a which prognosis? So it's having a poor prognosis. Okay, it's having a poor prognosis. Chalo, next, diagnosis. How to diagnosis? You are going with a CT angiogram. Okay, and what will this CT angiogram show? It will show us a narrowing. It will show us the narrowing of affected vessels due to this. Narrowing of affected vessels. Now very important question from the medicine and pathology that they have asked multiple times in your NEET PG exam, and they can ask in FMGE as well. Okay, now a angiographic classification of Takayasu arthritis. Okay, now you can see in this picture, guys, left subclavian artery is narrowing, and also here the affected arteries. Now it can lead to the aneurysms as well. I will teach you the complications of this Takayasu arthritis. Okay, it can lead to the aneurysms as well. Okay, aortic aneurysms. Okay, now let's discuss the classification. If the branch of the aortic arch is involved, that's going to be your type 1. Okay, ascending aortic arch and its branch is involved, that's going to be your type 2A. Okay, ascending aortic arch and its branch along with thoracic and descending aorta is involved, that's going to be your type 3B. Okay, then thoracic descending aorta, abdominal aorta, or renal arteries are involved, that is going to be your type 3. So that means the ascending aortic arch and its branches are spared in which type? Type 3. Okay, the abdominal aorta or the renal arteries, that's going to be your type 4, and combined features of type 2b and type 4 is called type 5. Type 3b is type 2b is going to be your ascending aorta, aortic arch and its branch, along with type 4 is going to be abdominal aorta, and combined the 2b and 4, that is your type 5 classification. Is that clear? So remember that they can give the picture and ask you it is type 1, it's type 2a, 2b, 3, 4 or 5. Is that clear? Is that clear to everyone? Okay, now what will be the treatment, guys? Well, treatment is going to be steroids. Treatment is going to be steroids. Okay, now the complications of this, so patient can have aortic aneurysms. Patient can have aortic aneurysms. The complication, patient can have a stroke as well. Okay, patient can have a limb ischemia. Okay, patient can have aortic regurgitation. Patient can have aortic regurgitation, or patient, due to the involvement of the renal arteries, patient can have a secondary hypertension. Patient will have a secondary hypertension. Here it's a left subclavian artery narrowing, and that completes your what? Takayasu arteritis. Okay, so a patient coming to you with a young female with a claudication in the forearm, there is a transient loss of the vision, she's having an abdominal pain, she has having a weak femoral pulse, your diagnosis is going to be a Takayasu arteritis. The subclavian artery is the most common one that will be involved. Okay, if coronary arteries is involved, patient is going to be having myocardial infarction. Renal arteries, there is an activation of the RAS and renovascular system. Okay, and visual distance is ICA. Chalo. Then medium vessel vasculitis. Then the medium vasculitis. Okay, now polyarteritis nodosa. Now if we talk about the medium vessel vasculitis, which affects the medium vessels, the classical topic that we are going to discuss is called as condition is called as polyarteritis nodosa. Okay, now this polyarteritis nodosa, it is seen in which patient, guys? Remember first one, sir, it's seen in young Asian. You will get the PDF for sure. It's seen in young adults. Okay, you can ping me on the Telegram as well, I will share the PDF, no problem. It's seen in the young adults. Okay, after that there is a presence of immune complex formation. There is a presence of immune complex formation, and the presence of immune complex formation. Okay guys, which type of hypersensitivity? Sir, type 3 we already discussed. Which type of necrosis will be seen with the pan? कौन सी necrosis मिलेगी pan में? Tell me. Which type of necrosis will be seen in a patient having a polyarteritis nodosa? Yes, which type of necrosis? So the type of necrosis seen with the polyarteritis nodosa we have already discussed. Yes, the fibrin and fibrinoid material deposits seen with the immune complex diseases. Type 3 hypersensitivity. 3. Very good. So patient is going to have which type of necrosis? Fibrinoid necrosis. We also studied. What are the other two conditions? Rheumatic heart disease we studied, and malignant hypertension. Okay, fibrinoid necrosis, not fibrinoid necrosis. Okay, and this polyarteritis nodosa, when an examiner will ask you a clinical case, he will mention that it is associated, it can be associated with hepatitis B infection. He will mention that hepatitis B history. Okay, hepatitis B, or also rheumatoid arthritis. RA के साथ भी दिखता है. Okay, after that the clinical features. First of all, fever, vasculitis, inflammatory condition है तो fever सब में ही दिखता है. Fever, fatigue, weight loss. Fever, fatigue and weight loss. But my dear students, if we talk about GIT, अगर GIT में involved है vessels, so patient will have a abdominal pain. patient will complain of abdominal pain. Along with that, patient will have melena. Okay, and this is all, it is due to what? Mesenteric artery ischemia. So mesenteric ischemia hota hai, that's why patient is having such features. Mesenteric ischemia. Okay, then if kidneys are involved, remember there can be aneurysm, there can be a inflammation, and eventually it will lead to what? It will lead to hypertension. Eventually it will lead to hypertension. But remember, kidneys are involved but there is no glomerulonephritis. Okay, kidney involved hai, but there is no glomerulonephritis. Now skin is involved, patient will complaining of rash. Okay, there will be ulcerative lesions, associated, or patient will have erythematous nodules. There will be erythematous nodules seen. Okay, after that, joints are involved, so patient will have a pain in joints and difficult in movement. There will be difficulty in movement. Is that clear? Is that clear to everyone? So there will be difficulty in movement. And remember guys, pulmonary vessels, okay, lungs are spared. Lungs are spared. So all these are the features of which? Pan, polyarthritis nodosa. All these are features of what, bacho? Polyarthritis nodosa. So patient having a fever, fatigue, abdominal pain, rash, all these are the features of polyarthritis nodosa. Now how to diagnose, sir? We'll go for an angiography. क्या करोगे? एंजियोग्राफी करोगे, एंजियोग्राम करोगे. Okay, and along with that you will see there is a which appearance? There is a string of beads appearance along the artery spasm. So if this picture is coming to you, see this artery is having a spasm, so this will have a what? String of beads appearance. Okay, string of beads appearance. This is an angiogram. Okay, and it gives the classical picture of what? String of beads appearance along with the artery which is having a vasospasm, which is having a artery spasm. Along with that we can go for the biopsy as well. हम biopsy भी करेंगे, and we can go for an hepatic serology as well, because it can be associated with what? Hepatitis B. We can go for hepatic serology as well. You can see a fibrin deposit or the fibrinoid material deposit. Which type of necrosis, guys? Fibrinoid necrosis. Fibrinoid necrosis, which is seen in which condition? Polyarthritis nodosa, which is seen in polyarthritis nodosa. What will be the treatment for the condition, bacho? So the treatment is going to be high dose steroids. The treatment is going to be high dose steroids. Along with that we can use a drug. We can use a drug called as cyclophosphamide. This anti-cancer drug, it also used in cancer. Now can you tell me the answer, then you tell me the side effect of this cyclophosphamide? This has been asked from the pharmacology. What is the side effect of the drug cyclophosphamide? Very good. What is the side effect of the drug cyclophosphamide? Yes sir, it causes hemorrhagic cystitis. Sir, it causes hemorrhagic cystitis. What is the treatment for hemorrhagic cystitis? That's going to be mesna. उसमें क्या देंगे? Mesna. That's going to be mesna. Okay, followed by that, if an examiner will ask what is the most common cause of death in case of a patient having pan, so that's going to be a renal failure. So that's going to be a renal failure. Okay, and you can see this fibrinoid material. Okay, this is going to be fibrinoid necrosis. Number second, the string of beads along the artery spasm in the angiogram. It's going to be a diagnosis feature. And then on the skin, the rash that I have mentioned, you can see there is erythematous. There is erythematous nodules with ulceration. with ulceration, and it is also seen with what? It is also seen with bacho, it's also seen with polyarthritis nodosa. Is that clear to everyone? Guys, this is very 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 important. Vasculitis से एक दो क्वेश्चन आते ही है, either from the medicine point of view or from which point of view or pathological point of view. Can we move to the next part? Can we move to the next question? All clear so far? Yes sir, all clear? Chalo. Yes sir. Next question. A child presents with a bilateral conjunctivitis, peeling of the skin and the fever since 5 days. What is the likely diagnosis? So you have a patient coming to you, he's a child, okay, having a conjunctivitis, peeling of the skin, okay, along with that patient is having a fever. What will be your diagnosis? Questions might seem very easy, but the main motive of these questions is not to remember the questions, remember the full topic, because it's not a PYQ that is important, it's what? A previous year topic that's going to be your important. Okay, so a child presents with a bilateral conjunctivitis with the peeling of skin and the fever since 5 days. What is your likely diagnosis? What will be the likely diagnosis? Yes, write down. What will be the likely diagnosis? Very good. You cannot write sir maybe, both simple hai na? Conjunctivitis, rash, fever, that's going to be Kawasaki disease. That's going to be a Kawasaki disease. Now let's discuss what exactly is this Kawasaki disease. Sir, it's also called as this Kawasaki disease, it's also called as mucocutaneous. It's also called as mucocutaneous lymph node syndrome. It's also called as mucocutaneous lymph node syndrome. Okay, it usually affects the kids age less than 4 years. Age less than 4 years. Okay, now what are the clinical features? You remember? Crash, C-R-A-S-H, crash or cream. Okay, na? Crash or cream. Okay, now C, what is C? C is going to be sir conjunctivitis. C is going to be your conjunctivitis. My dear students, recent questions that have been circulating, which of the following is not a feature of a Kawasaki disease? They will mention purulent conjunctivitis. Remember, that is a non-purulent. Ab expire ho gaye sare questions. Now new questions are which of the following feature is not seen? So it's non-purulent. Okay, which of the not seen? Purulent discharge is not seen, that is non-purulent. Okay, now R stands with rash hoga. Then A is going to be adenopathy. Okay, cervical adenopathy. Okay, then S is going to be a strawberry tongue, and this strawberry tongue is also seen in this strawberry tongue is also seen with the patient having what? Having, yes, tell me, scarlet fever. Okay, and the strawberry gums, vaginal granulomatosis. Okay, strawberry vagina, also called as colpites macularis, that's called as a trichomoniasis. Okay, trichomonas vaginalis, trichomoniasis. Okay, chalo. H is going to be hand and feet swelling. H is going to be hand and feet swelling. Is that clear? Or edema? Edema hoga. Okay, you will see a palmar and the plantar erythema along with the swelling. Okay, so these are the features of a patient having what? These are the features of a patient having a Kawasaki disease. And due to the involvement of the coronary arteries, patient can have a myocardial infarction. So cardiac causes are the cause of death in case of a Kawasaki disease. Along with that, sir, patient will have more than 5 days of fever. Patient will have more than 5 days of fever associated with Kawasaki disease. Okay, now what are these features? Number one, this rash, okay, seen, is called as macropapular rash. So this is a macropapular rash. Okay, now if I will see this one, image B, so this is going to be a conjunctivitis seen in Kawasaki disease, non-purulent. Okay, image number C, this is going to be a strawberry tongue. That is going to be a strawberry tongue. That is going to be a strawberry tongue. Okay, then C, you can see patient is having a erythema on the hands. Okay, and a hand swelling. I already mentioned hand and foot swelling. Okay, in case of a patient having what, Kawasaki disease, you can say feet swelling as well, plantar erythema. Okay, palmar erythema and plantar erythema. This is going to be patient having a cervical lymphadenopathy. Cervical adenopathy. It's going to be cervical adenopathy. Okay, here you can see patient is having coronary artery aneurysm in the picture. Look at the picture, guys. It's pointed, having what, coronary artery aneurysm. That's why patient can have myocardial infarction, and the cause of the death is cardiac. Coronary artery aneurysm. And here patient is having which artery aneurysm? Peripheral artery aneurysm as well. Peripheral artery aneurysm. Okay, so this picture all defines Kawasaki disease. Patient is having a plantar erythema with a fetal swelling, palmar erythema with a hand swelling, strawberry tongue, conjunctivitis, maculopapular rash, peripheral artery aneurysm, coronary artery aneurysm, cervical adenopathy, and a feet swelling. Okay, and what will be the treatment, bacho? Now what will be the treatment given? What will be the treatment given to this patient? What will be the treatment given to this patient? You already know, sir. Will give IV immunoglobulins. IV immunoglobulins. Along with that, we give one more drug, aspirin. It's the only condition in the children's where we give aspirin. That's going to be Kawasaki disease. What is the side effect of aspirin? What is the side effect of an aspirin in kids? What is the side effect of an aspirin in the kids? Side effect of the aspirin in the kids. Started with R. Which syndrome it can cause? Yes, side effect, Ray's syndrome. Very good. So the only condition, sir, we are giving aspirin is going to be, only condition we are going aspirin is Kawasaki. Otherwise it causes Ray's syndrome. It causes Ray's syndrome. And remember, acute gout mein all the NSAIDs can be given except, wahan pe bhi except hai, that's going to be a aspirin. That's going to be a aspirin. Okay, except acute gout mein aspirin. Okay, all clear so far? Now let's move to the Berger's disease. Okay, very important again, Berger's disease. So it's also called as this Berger's disease. It's also called as thromboangiitis obliterans. It's also called as thromboangiitis obliterans. Okay, it's seen in young male. It's seen in young male. Usually the clinical case will mention that a patient is a smoker. Okay, patient is a smoker. So other risk factors that it can have, that the patient can develop thromboangiitis obliterans. Patient might have a increased cholesterol, hypercholesterolemia. Patient might have increased triglycerides. Okay, patient might be having a hypercoagulable state. Okay, or patient might have a type 2 diabetes. Patient might have a type 2 diabetes. Okay, now this Berger's disease, what is happening? There is an occlusion of a small and medium sized vessels. There is occlusion of small and medium sized vessels. Okay, and the arteries that are involved is your tibial artery that is involved, so that's going to be your tibial artery and a radial artery, usually tibial artery or radial artery. That's why when the decreased blood supply is there, ischemia is there, necrosis ho sakta hai. You can see the picture, black necrotic tissue over there. Okay, and smokers will be the history. They will not mention sometimes Berger's disease, they can mention thromboangiitis obliterans, TAO, thromboangiitis obliterans. Okay, now so what are the clinical features? You remember with the mnemonic scrap, scraps. S is going to be segmenting thrombosing vasculitis. Okay, C with claudication. Which claudication? Intermittent claudication or in-step claudication. Intermittent claudication. Okay, R, it is associated with Raynaud's phenomena. Yes, now again one more question that has been asked: what is the color sequence? What is the color sequence in the Raynaud's phenomena? What is the color change sequence in the Raynaud's phenomena? I'm writing it here only. And this Raynaud's phenomena, sir, it is due to the involvement of the which artery? Such it is due to the involvement of the tibial artery, number one condition. Number second, sir, this Raynaud's phenomena, we have a color change, appearance. We have WBR, that is white, blue and red. So Raynaud's phenomena mein treatment is calcium channel blockers. That's going to be calcium channel blockers. Remember this, WBR, Raynaud's phenomena. Okay, after that, A is, it's associated with smoking. A, it is associated with smoking. Okay, P, there is pain even at rest. Pain even at rest. And S, there is superficial nodular phlebitis. There is superficial nodular phlebitis. And what will be the treatment? First of all, tell a patient quit smoking. Then the decreased blood flow is there, so we'll give a vasodilators. Okay, along with that we also need surgery, amputation karna padta hai. And if there is a high cholesterol levels, high triglyceride levels, treat the cause. Okay, treat the cause. Is that clear? So that is your thromboangiitis obliterans. Sir, how to diagnose? You go for angiography or duplex scan. So a smoker is coming to you with a complaints or with a given clinical picture of a black necrotic tissue. You suspect what? You suspect the thromboangiitis obliterans, okay, or Berger's disease. What are the features? Sir, segmenting thrombosing vasculitis, claudication, Raynaud's phenomena associated with smoking, pain even at rest, and superficial nodular phlebitis. Treatment: quit the smoking and clear the cause. Is that clear to everyone? Arteries involved is the tibial artery. That's why patient is having what? Raynaud's phenomena. Aage badhu? Can we go ahead? Yes, we'll finish in this part only, just a little much. Chalo, next. Now a small vessel vasculitis. Okay, now most common small. So first one that we're going to discuss is Wegener's granulomatosis. Okay, that's going to be your Wegener's granulomatosis. Okay, it's also known as granulomatosis with polyangiitis. It's also known as granulomatosis with polyangiitis. It's characterized, this Wegener's granulomatosis, which is affecting the small vessels, it is characterized by the presence of a necrotizing granuloma. Necrotizing granuloma in upper respiratory tract or lungs. In upper respiratory tract and lungs. This is a Wegener's granulomatosis and the granuloma seen Okay, there is an involvement of the triad. Okay, कैसे रखोगे याद? RUL triad. First is renal, U is going to be upper respiratory tract, and L is going to be lower respiratory tract. So what is a triad, bacho? Sir, it's involving renal, upper respiratory tract and lower respiratory tract Now Wegener's granulomatosis में if we talk about the upper respiratory tract, E में क्या आएगा? Ear आपका. Ear में क्या होगा? Patient will have a otitis media. क्या हो सकता है patient को? Otitis media. N, that's going to be nose. Patient can have septal perforation. Okay, or patient can have a saddle nose. You can see patient can have a saddle nose. Okay, or patient can have a nosebleed as well. Abstraxis भी हो सकता है, ठीक है ना? Abstraxis भी हो सकता है. Okay, then T, patient can, teeth में क्या लिखोगे? Patient can have strawberry. Patient will have strawberry gums. Okay, that's E and T. Then the lungs में क्या होगा? Lung features में patient will complain of pneumonia. Patient को pneumonia हो सकता है. Along with that, some patient can have a cough, or some patient can have a hemoptysis. So hemoptysis किस वाली vasculitis में? That's a Wegener's granulomatosis or a granulomatosis with polyangiitis, or the granulomatosis with the polyangiitis. After that, if the kidney is involved, okay, crescentic glomerulonephritis. Which one is that? That's going to be RPG, and crescentic is RPGN, है ना? Now tell me guys, starry sky appearance, that's going to be your PSGN. Starry sky appearance, PSGN. Okay, effacement of podocytes, that's going to be your minimal change disease. Effacement of podocytes, minimal change disease. Basket wavy appearance, that's going to be your basket wavy Alport's syndrome. That's going to be your Alport's syndrome, type 4 collagen defect. ठीक है ना? With a triad of can't see, can't pee, can't hear. Can't see में क्या आएगा? Anterior lentigonus. Okay, can't pee, hematuria and SNHL. Is that clear? So how to diagnose this? Very important question. CN का. Okay, how do you remember? World Cup. WC is World Cup. W for Wegener's granulomatosis and C for CN का. ठीक है? We also go for biopsy. And biopsy पे क्या मिलेगा? Necrotizing granuloma. क्या मिलेगा? Necrotizing granuloma. Patient will have a necrotizing granuloma. What will be the treatments? So we will give immunosuppressant agents. Okay, cyclophosphamide, and we also use rituximab. These are the two drugs that are used in a Wegener's granulomatosis. Okay, so you have already mentioned kidneys are involving crescentic RPGN. Okay, you can see gums, having a strawberry gums, okay, or tight media हो सकता है ear को involve करके, and it's due to the inflammation of medium and small size vessels, okay. Nose will be involved, patient will have a septal or nasal perforation, okay, or septal defect, okay, or a stuffiness reninosus or an epistaxis. That's all about your Wegener's granulomatosis. Is that clear to everyone? Is that clear to everyone? Yes. Is that clear to everyone? So it's also known as granulomatosis with the polyangiitis, necrotizing granuloma, तीन चीज़ें, renal, upper and lower, otitis media, septal perforation, strawberry gums, pneumonia, RPGN. Okay, RPGN if involved, now you have a vasculitis in your mind, that's going to be your Wegener's granulomatosis. Is that clear? Now let's move to the next one question. Is that clear so far, everyone? Please write down in the comment section. Yes. I am going a bit faster because this is not the main session, but yes, all these topics that we are discussing are the main topics, whether it could be a thyroid, whether it could be a intracellular pigmentations, whether it's a necrosis, apoptosis, vasculitis, okay, all these are what? Very, very important, okay. Chalo, now tell me, my dear students, everything is clear so far? Jaldi se bata do comment section mein so we can go ahead. Yes. Yes sir, all good, speed is okay. Chalo, yes sir, good. Chalo, a 5-year-old child presents with a colicky abdominal pain and purpuric skin lesions on extensor surfaces of the arms and legs. The urine analysis showing hematuria and mild proteinuria. What will be the most probable diagnosis? What will be your most probable diagnosis, bachcho? So a 5-year child presents with abdominal pain, purpuric lesions, extensor on the surfaces in the arms and legs. Classical picture, ये वाली picture है, बच्चा आ रहा है ये वाली picture लेके, okay, and hematuria is there and a mild proteinuria. So you already know that it's Hinosh-Schönlein purpura. It's Hinosh-Schönlein purpura, HSP. Now let's discuss about this. Okay, so it's a most common vasculitis. It is a most common vasculitis in pediatric age group. It's a most common vasculitis in pediatric age group. Okay, it is having which type of hypersensitivity? 3 letters. So type 3 hypersensitivity reaction. Okay, along with that, so patient will give a history of upper respiratory tract infections, and there is increased level of which immunoglobulin IgA. Okay, now if we talk about the clinical features of a patient, if we talk about clinical features, in clinical features बच्चों, number 1 is going to be kidney is associated. Kidney involved है तो patient को क्या होगा? Hematuria, blood. Okay, second one, if we talk about a skin related problems, there will be a rash on extensor surface. Rash on extensor surface and buttocks. Okay, that's going to be skin. Okay, if remember platelet count is normal. Platelet count is normal. Okay, it is non-thrombocytic purpura. They will mention, क्या mention करेंगे question में? It's a non-thrombocytic purpura. Sir, it's a non-thrombocytic purpura. Okay, along with that, if we talk about a GIT is involved, from the GIT patient will have a which symptoms? A patient is complaining of abdominal pain. Patient is having abdominal pain. And if we talk about joint, patient is having a joint pain or swelling. Joint pain or swelling. Okay, how to diagnose? You go with the You go with the diagnosis कैसे करोगे? So we go with a skin biopsy. Yes, colicky pain, skin biopsy. Is that clear? So that's all about what? HSP. You can see the rash on the legs, okay, or extensors or buttocks, okay. Along with that, you can see there is a IgA antibody. There is IgA antibody deposition at dermal papillae, at dermal papillae. Is that clear? There is an IgA antibody deposition. So that's your Hinoch Schollin purpura, HSP. Is that clear? So it's the most common vasculitis in the pediatric age group, type 3 hypersensitivity. So it's HSP, 3 letters. So having a type 3 hypersensitivity, SLE, again type 3 hypersensitivity. So clinical features of hematuria, abdominal pain, arthralgia, joint pain, okay, and it's a non-thrombocytic purpura, non-thrombocytic purpura. The patient will give a history of an upper respiratory tract infection, upper respiratory tract infection. Chalo, next one is going to be the last one. It's going to be Behçet's disease. Okay, that's your Behçet's disease. So what exactly is Behçet's disease? It's also known as oculo-oral genital syndrome. Oculo-oral genital syndrome. Okay, it's a small vessel vasculitis. It is a small vessel vasculitis. Okay, it is associated with HLA B5 or B51. Okay, there is a classical triad. Okay, remember the triad. Most common will be oral ulcers, then patient will have genital ulcers, then patient will have uveitis, then so can't see genital ulcers, anterior uveitis with a hypopyon, and patient is having a oral ulcers. Is that clear? So all these are seen in which condition, guys? Behçet's disease. That's why it's also called as oculo uveitis, oral ulcers, genital ulcers, oral oculo-oral genital syndrome. Okay, association which HLA? B5 and B1. Okay, so what are the drugs? What is the treatment for this condition? The drug you will give is your infliximab, monoclonal antibodies, infliximab, and you can give adalimumab for the treatment, adalimumab. Okay, and if we talk about for the antibodies which are present, anti-endothelial cell antibody present. The name of the test that we do for this Behçet disease is called as Pathology test. क्या है नाम टेस्ट का, guys? For the diagnosis, sir, the test name is Pathology test. The test name is Pathology test. Okay, so that completes your all vasculitis: large vessel, medium vessel, and small vessel vasculitis. Is that clear to everyone? Is that clear to everyone? Yes, all of you in the comment section, all clear? Now let's discuss the important tumor markers. Okay, so they can ask you some conditions. Okay, they can give in a clinical case that the tumor marker calcitonin or P53, PSA, catecholamines, they are all increased. Okay, so depending upon the tumor marker, we'll try to integrate all these tumor markers with their conditions, so that at least क्या होगा, revision होगा. Is that clear? So let me write the first one, the calcitonin. Calcitonin is a tumor marker for which condition? Revise with me. So calcitonin is a tumor marker for medullary thyroid cancer. Okay, now let's revise this medullary thyroid cancer here only. So medullary thyroid cancer, what is the tumor marker? Sir, the tumor marker is going to be a calcitonin. What is the tumor marker, bacho? Tumor marker is going to be calcitonin. It arises from which cells? Sir, it arises from parafollicular C cells. It arises from which cells, bacho? Parafollicular C cells. This medullary thyroid cancer, M for medullary, it's associated with which syndrome? Men 2A syndrome. It's associated with which syndrome, bacho? Men 2A syndrome. Also, along with that, medullary carcinoma thyroid mein kya pada? It is seen, it's on biopsy, on HP, we have seen amyloid rich stroma. That's why amyloidosis is seen with which cancer? Medullary thyroid cancer. And if calcitonin is negative, we go with the CEA, and the gene mutation is RET gene. So that's all about your medullary thyroid cancer. So whatever guys, whatever tumor marker I'm associating with the condition, whatever you know about that condition, type in the comment section, whatever you can recall. So let's integrate these tumor marks with the full topics. Okay, हम इन सारे tumor marks को let's integrate them. Is that clear? Whatever you know about a particular condition, मैंने बीटा HCG बोला, ectopic pregnancy बोल दो, molar pregnancy बोल दो, any condition, tumors बोल दो. I said about cat column means, say everything about the cat column means you remember. So let's integrate this last two slides so that you will recall and revise more, because it's a last lap. Okay, so let's try to integrate, or the more information should be delivered. Is that clear? So calcitonin, we already know, sir, it's a tumor marker of medullary thyroid cancer. Number one step. Number second, sir, it arises from the parafollicular C cells. Number third, sir, it is associated with the MEN2 syndrome. Number fourth, sir, it marker is calcitonin. If negative, we go with the CEA. Number fifth, sir, the gene associated is RET mutation. RET mutation. Now second one is going to be alpha fetoprotein. Now tell me about alpha fetoprotein. कहाँ पे मिलता है alpha fetoprotein? Sir, it's seen in yolk sac tumor. कहाँ पे? It's a tumor marker for yolk sac tumor, and it's a tumor marker for hepatocellular carcinoma. It's a tumor marker for hepatocellular carcinoma. Now which hepatitis causes hepatocellular carcinoma? That's going to be hepatitis C, chronic C cancer. Hepatitis C. Also B causes, but utne zyada nahi. Hepatitis C with a hepatic carcinoma. Okay, now tell me, OCPs cause also what? Hepatic adenoma. Let's integrate. OCPs also cause what? Hepatic adenoma. So yolk sac tumor and HCC, that's going to be alpha fetoprotein. Alpha fetoprotein. Now if we talk about beta HCG, beta HCG is increase in, sir, कहाँ पे increase होता है? Sir, it's increase in choriocarcinoma. You already know, hydrated form mole versus then conditions can have choriocarcinoma. And if this choriocarcinoma goes to the lungs in the stage 2 or stage 3, it goes into the lungs. What is the classical appearance in the lungs, bacho? What is the classical appearance? Yes sir, we integrate it. The classical appearance is called as cannonball metastasis. वो cancer आता कहाँ से? choriocarcinoma से. And also this increased HCG, which condition? It is seen in the germ cell tumors. Which conditions? Germ cell tumors. So choriocarcinoma, germ cell tumor, okay, or a hyperemesis gravidarum, okay, more and more vomiting, that is seen with the beta HCG. Sir, beta HCG is coming from where? Sir, it's coming from a syncytotrophoblast. कब होता है? syncytotrophoblast से आता है. Sir, maximum beta HCG, one more MCQ, that's going to be on which day? किस day में मिलता है? 66th day. There is increased HCG, and this increased HCG, it is cause of increased emesis, and this increased emesis, patient is having metabolic alkalosis. Patient is having what? Metabolic alkalosis. Next is going to be PSA. You already know, sir, PSA with the prostate cancer. Okay, prostate cancer. Let's integrate a bit about prostate that has been asked multiple times. That's going to be your benign prostate hyperplasia. Old man will come with a difficulty in the urinating. There's a micturition, okay, and there is also a post-vital urine over there. So what has happened? There's an increase of the cells of prostate, benign prostate hyperplasia. So what exactly they ask? The drug they will ask you. What is the drug we give to decrease the size of the prostate? We use a 5-alpha reductase inhibitors, a drug called as finasteride, okay. Number second drugs, we also use a tamsulosin. Very good. We also use a alpha 1 blockers, prazosin. We also use a prazosin, tarazosin, tamsulosin and finasteride. Very good, sir. The score for that is called as Gleason score. Very good. The score for that is called as Gleason score. That is that's FMGE PYQ 2022 June. Simple question. What is the drug? What is the score for prostate cancer? Gleason score. Very good. Benign prostate hyperplasia. Very good. Finasteride हो गया. What is the side effect of alpha 1 blocker that is used in a patient having a BPH? Alpha 1 blockers का क्या होता है सर? Orthostatic hypotension, and for that drug of choice is going to be your midodrine. For that drug of choice is going to be your midodrine. So that is prostate cancer, Gleason score, ठीक है ना, and all other things. Now catecholamines, okay, catecholamines sir, it is seen in, it's a tumor marker for which condition sir? That is a pheochromocytoma. Okay sir, so that is a pheochromocytoma. Now this pheochromocytoma, you already know this is a tumor of a adrenal medulla. Okay, very good. This is a tumor of a which condition? Adrenal medulla. And when I talk about the tumor of an adrenal medulla, for a particularly which cells? That is going to be your chromaffin cells. That's going to be your chromaffin cells. And what are the triad of this? Patient is having a headache, patient is having a palpitation, and patient is having a sweating. So headache, palpitation and sweating. Headache, palpitation and sweating. What is your answer, bacho? So pheochromocytoma. Very important thing, sir. Tumor of 10%, okay, then remember those 10%, what are all the conditions? After that, there is a pathological pattern of the cells called as Zella-Bellane cells. What are the cells? Zella-Bellane cells. Is that clear? Then metanephrine levels is going to be investigation of choice, but we can also go for the screening of VMA levels. Now yes, other site, organ of Zuckerkandl. Very good, organ of Zuckerkandl is an extra site for that. After that, we have discussed the treatment in our classes. What can be the treatment of a pheochromocytoma? 3 conditions: before surgery, during surgery, after the surgery. Before surgery, sir, I'm giving a phenoxybenzamine. What is the drug before the surgery? Phenoxybenzamine. During the surgery, I'm giving a phentolamine. Cheese reaction के साथ भी associated. After surgery, I'm using a alpha plus beta blocker. That's going to be labetalol. That is going to be your labetalol. Is that clear to everyone? Pheochromocytoma याद रखा. Metanephrine levels, phenoxybenzamine before, during surgery phentolamine, after surgery is going to be your labetalol. Is that clear? Phenoxybenzamine question was asked. It is a which class of drug? Alpha 1 adrenergic. ठीक है ना, alpha 1 adrenergic. That is your pheochromocytoma. ठीक है sir, this is also used in, this catecholamines are also used in neuroblastoma. This catecholamines, epinephrine, non-epinephrine, ये आता किस amino acid से? They are coming from tyrosine. Remember that, they are coming from tyrosine. They are coming from which condition? They are coming from tyrosine. So pheochromocytoma is clear. चलो आगे बढ़ते हैं सर. CEA, sir, CEA we all know it is for a colon cancer. So colon cancer, okay, it is for which colon cancer? We have a Negro's regime as well. Colon CA, अभी हमने पढ़ा. If a medullary thyroid cancer patient having a negative calcitonin, the other investigation used is going to be your CEA, and this is also seen with CEA. Which cancer? So pancreatic cancer. Which cancer, sir? Pancreatic cancer. So pancreatic, you already know sir, it can be acute pancreatitis, chronic pancreatitis, है ना. अब pancreatitis में कौन सा स्कोर होता है? Yes, pancreatitis में कौन सा स्कोर होता है? BSAP score. Yes sir, one more score is there, Ranson score. For which condition? Pancreatitis. Investigation of choice in acute pancreatitis is going to be your serum lipase. पहले amylase करोगे, but when it comes 3 times more than that, you go with the serum lipase. So what will be the investigation of choice for chronic pancreatitis? That is going to be your CECT, contrast enhanced CT. Is that clear? Then we have a criteria for that. We are going to have a criteria. Name of the criteria is a Balthazar criteria, okay, and that tells us about the severity of the chronic pancreatitis. Then you go with that particular condition. Now chain of Lake's appearance, chronic pancreatitis. Remember that chain of Lake's appearance aega question. Chain of Lake's appearance, what is your answer? That's going to be a chronic pancreatitis. Chain of Lake's appearance is chronic pancreatitis. Most common tumor of pancreas, it's going to be insulinoma. दूसरा क्वेश्चन, Whipple's triad. Remember Whipple's triad. Remember the most common tumor, insulinoma. Okay. After that, what's the most common congenital defect of the pancreas? Your answer is going to be pancreatic divism. क्या होगा आंसर? Pancreatic divism. I'm not writing these things. I'm just going with the flow so that you can remember these all questions as well. So chain of Lake appearance, CECT. Okay, and one more is a most common congenital defect of the pancreas. That's going to be pancreatic divism. Is that clear? So that's all about pancreas. ठीक है, चलो CA72-4. So that's going to be a stomach cancer. So that's going to be a stomach cancer. Okay, stomach cancer में drug GIST में कौन सी drug देते हैं? That's going to be your GIST में कौन सी drug देते हैं? Yes, very good. Remember imatinib. Imatinib is also used in CML. पहला point. Second point in stomach cancer is if this stomach cancer goes to the ovaries, gynae के साथ करेंगे integrate. If this stomach cancer goes to the ovaries, it's called as Krukenberg tumor. It's called as Krukenberg tumor. And Krukenberg tumor which having which cells? Signet ring cells. Now sir, this stomach cancer अब क्रूकनबर्ग से ब्रेस्ट से भी आता है, आई नो क्रूकनबर्ग also coming from breast, but the first choice is going to be your stomach cancer. First choice is going to be your stomach cancer having a signet ring cells. If the question asks which of the following cancer is associated with a patient having a Krukenberg tumor, which breast cancer, your answer is going to be invasive-lobular carcinoma. Invasive-lobular carcinoma. Number second thing, now this stomach cancer can go to the different sites. It goes to the pouch of Douglas, Blummer shelf, ठीक है ना, it goes to the umbilicus, sister Jones-Mary nodules, then it goes to the clavicles and all. Remember those things. Krukenberg हो गया, Blummer shelf हो गया, sister Jones-Mary nodules हो गया, Virchow's node हो गया. Remember all that stuff according to for the stomach cancer. Is that clear? And stomach cancer is also caused by H. pylori, है ना, H. pylori can cause stomach cancer. CA19-9, sir, it is seen in a pancreatic cancer. Sir, it is seen in a pancreatic cancer. Also, sir, it's seen in the colon cancer. CA19-9, pancreatic cancer and colon cancer. Okay, what is the name of the stage? What is the name of the staging? Duke staging for the colon cancer. Which is the staging? Duke staging. Duke criteria for infective endocarditis. Duke score. Duke score for coronary artery diseases, heart के लिए. Duke staging for colon cancer. Is that clear? CA15-3, that's going to be your breast cancer. So breast में क्या है? Most common gene associated with the breast cancer. What will be your answer? Most common gene associated with the breast cancer. So answer is going to be P53. Then greenish discharge, duct ectasia, red discharge, duct papilloma. Okay. Then thrombophlebitis of the breast is Monders disease. Okay. Giant breast tumor, phylloids tumor. Okay. Then patient coming to you with a popcorn calcification on mammography, that's a 30-year-old with a mobile mass, Mickey Mouse sign, that's going to be your fibroadenoma. So breast clear. After that, CA125, that's going to be your ovarian cancer. That's going to be ovarian cancer, mucinous cyst adenoma, serous cyst adenoma, Brenner tumor, and endometrial tumor. All these four are the epithelial tumor cells. Okay, then a tumor, ovarian cancer having a teeth and hair-like structures, that is going to be your teratoma. Then a patient having a high estrogen levels, along with that on examination we have a rosette-shaped bodies or a Karl-Exner bodies. That's a classical case of a granulosa cell tumor. Okay, then you study Brenner's tumor with the Seromague syndrome, fibroma ovary with the Meige syndrome along with the ascites and pleural effusion. Okay, then Samoma bodies with the serous cyst adenoma. Okay, then you study a pseudomyxoma peritoni with a mucinous cyst adenoma, bladder-like cells with a Brenner tumor. Is that clear? So all these about ovarian cancers is also very important. Is that clear? Then 5-HIAA. Okay, that is going to be your 5-hydroindole acetic acid. So 5-HIAA किसके साथ मिलता है? Carcinoid tumor. सर ये carcinoid tumor कब होता है? When there is increased level of what? Serotonin. Increased level of serotonin. This serotonin is coming from your tryptophan. Okay, तो patient को क्या होता है? Clinical features of the carcinoid syndrome, patient complaining of a watery diarrhea. ठीक है? And what's the drug you use in the carcinoid syndrome? The answer is going to be your octreotide, which is a somatostatin analog, Is that clear? 5-HIAA, carcinoid syndrome, serotonin increase. 5-HIAA is an investigation of choice for the carcinoid syndrome as well. So drug we use is octreotide, somatostatin analog. ये octreotide कहाँ पे use करते हो? Acromegaly में भी use करते हैं. Remember that. Is that clear? Octreotide is also used for esophageal varices along with the terlipressin. Then LDH is seen in dysgerminoma, ठीक है ना, dysgerminoma and lymphoma. Again the ovarian tumors already discussed. After that CD99 or MYC2 gene, that's onion peel appearance, Ewing sarcoma. ठीक है, onion peel appearance, Ewing sarcoma, CD99 or MYC2 gene, है ना. Then sunburst is going to be your osteosarcoma. Giant cell is a giant cell tumor of the hand, you know that. But what is the another name of a giant cell? They will mark osteoclastoma. Clastoma लिखना, ठीक है. Giant cell tumor का दूसरा नाम क्या है? Osteoclastoma, ठीक है. And then beta-2 microglobulin, beta-2 we already discussed, अभी तो पढ़ा था. A beta-2 भी, that is multiple. A beta-2 sorry in the kidneys is now beta-2 microglobulin in multiple myeloma. Remember that multiple myeloma में कौन सी drug भी use करते हैं? Tocilizumab, which is the interleukin-6 inhibitor. ठीक है ना? So this is all about your tumor markers. As much as we could integrate it, we tried. Okay. Now, yes, osteoclastoma. Okay. So that's all about your tumor markers. Is that clear to everyone? Clear हो गया? Yes. multiple myeloma. Yes, multiple myeloma, maybe you will have that. Yes, चलो on the skull, which lesions on the skull of multiple myeloma में, अब skull में multiple myeloma में कौन सी ये देखेंगे? Tell me about the skull. Salt and pepper hyperparathyroidism, skills, needle shape on the skull, that's your skill cell anemia. Okay, then raindrop, multiple myeloma, lytic lesions. Yes, chalo. Yes, it's clear so far, all of you? Chalo, next. Can we move to the next part, बच्चों? Punched out lesions, हाँ, raindrop. Sir, yes. Very good. C mic, N mic. Yes, C mic, N mic is also important. Remember that. C mic कहाँ होता है, N mic कहाँ होता है, neuroblastoma. Okay. Remember that as well. चलो. Can we move ahead, guys? सर केरास कहाँ होता है? केरास कोलोन कैंसर म्यूटेशन. ओके, दैट इज अ प्रोटो ऑन्कोजीन. हु इज दैट? मोहम्मद अनस. ठीक है ना. सी माइक बर्किट्स लिम्फोमा, ट्रांसलोकेशन 814, स्टारी स्काई अपीयरेंस, अफ्रीका, ईबीवी. ठीक है, याद रखो. देन एन माइक न्यूरोब्लास्टोमा एंड एल माइक इज गोइंग टू बी लंग कैंसर. एल माइक इज गोइंग टू बी लंग कैंसर. ठीक है, इज दैट क्लियर? केरास कोलोन कैंसर. चलो, प्रोटोन को जीन्स. लास्ट वन. एवरीथिंग इज क्लियर सो फार? चलो, we couldn't write all the things that we have integrated, but yes, as much as we could, we did. So next, a graft from identical twins. बच्चा क्वेश्चन तो देगा ही examiner, some easy questions as well. So the identical twins, what is the graft बच्चों? What is the name of the graft? So the name of the graft is going to be isograft. Iso means same, so identical twin से आएगा तो same graft. ठीक है सर. what is allograft? Write it down. what is allograft? allograft का मतलब होता है transplant between two different individuals. It's transplant between two different individuals. What is autograft बच्चों? Autograft is when the donor and recipient is same. When the donor and recipient is same. What is isograft? Same identical twins. Same identical twins. What is xenograft? Xenograft between animal and human being. Transplant between animal and human being. Is that clear? Is that clear? Now this is about a organ transplant. Okay, now if we talk about a graft rejection, we have sir hyperacute. ये भी क्वेश्चन पूछा है सर. We have hyperacute, sir. We have acute and we have chronic. We have chronic. Okay, hyperacute कब होता है सर? Onset is immediate. Sir, onset is immediate. Sir, acute, it goes to weeks to months. It is weeks to sorry, it goes to the weeks and months. Weeks to months. And chronic, it's months to years. The question has been asked from the PYQ that after the kidney transplant, which infection is seen most common? The answer is going to be CMV. क्या होगा आंसर? CMV. Okay. Then if we talk about the type of hypersensitivity reactions, okay, type 2 followed by type 3. Hypersensitivity reactions involved. यहाँ पे 2 followed by 3. Okay, here it's type 4 involved. Okay, और यहाँ पे it's type 3 and 4. That is a hypersensitivity reactions involved with the chalo. Okay, and C, acute and chronic rejection, they are T cell mediated. Remember that's a T cell mediated. Is that clear? So that is about a graft rejection. That's about a graft rejection and organ transplant. Graft rejection and organ transplant. Graft rejection and organ transplant. Now let's discuss about a trinucleotide repeats. A trinucleotide repeats you already know, and how the clinical case will come from the trinucleotide repeats. Okay, chalo. Now you already know. First one, Huntington's chorea. Okay, now this Huntington's chorea, what is the trinucleotide repeat? That is going to be your CAG. What is the trinucleotide repeat in Huntington's chorea? CAG. So a 40 to 50 year patient will come, okay, who is aggressive, who flails his arms, writhing body movements, chorea हो रहा है, and has a family history of this given condition. Your answer is going to be, sir, Huntington's chorea. They will ask what is the trinucleotide repeat in the condition. Your answer is going to be CAG. Okay, now this Huntington's chorea किस क्रोमोसोम पे होता है सर? इट इज एसोसिएटेड विद क्रोमोसोम नंबर 4. कौन से क्रोमोसोम नंबर पे? 4. ओके, एंड व्हाट इज हैपनिंग एग्जैक्टली सर? डोपामीन जो होता है, डोपामीन बढ़ता है और एसिटाइल कोलिन कम होता है. ओके, डोपामीन कम कहाँ होता है? पार्किंसंस में. ओके, एंड रिमेंबर नाउ व्हेन द डोपामीन इज इंक्रीज, पेशेंट इज हैविंग, क्या होता है पेशेंट को सर? कोरिया, abnormal body movements. Now what will be the treatment when the patient is having a dopamine increase? So the drug I will give is a dopamine depleter. Drug I will give is a dopamine depleter, जो dopamine को कम करेगा. What is the name of the drug? Sir, I will use, yes, write down in the comment section. I will use, yes, anyone in the comment section? Very good, it is tetrabenazine. It is tetrabenazine, okay, or valbenazine. Just write tetrabenazine. The drug of choice is tetrabenazine. Okay, tetrabenazine. Chalo. Chromosome number 4, chorea. Now GAA is Friedreich's ataxia. A 15-year-old male will come with a broad-based gait, diabetes, and exam showing scoliosis. Patient has a loss of sensation in his feet. So trinucleotide repeat is going to be GAA. Okay, GAA. Okay, then a myotonic dystrophy. Okay, a 30-year-old male has noticed himself being off balance, hair loss, exam shows a failure to relax, and after shaking the hand with the doctor. So myotonic dystrophy. Myotonic dystrophy is CTG, and there is a classical cataract seen. What is the name of the cataract? So the name of the cataract is Christmas tree cataract. The name of the cataract is Christmas tree cataract. Seen in which condition? Myotonic dystrophy, CTG. Then we have different cataracts as well. Rosette shaped cataract as in a trauma, blunt trauma. Then we have a snowflake cataract seen in a diabetes with the accumulation of a sorbitol because it affects the sorbitol pathway. Then we have an oil drop cataract seen in a galactosemia. There is an accumulation of the galcetrol, and galactosemia is a contraindication for the breastfeeding. Number 1. Number 2, the enzyme deficient is going to be your galput. Number 3 thing, you have one more cataract. We have a sunflower cataract. Okay, and the sunflower cataract is going to have which condition? That's going to in the Wilson disease with the copper increased. Okay, copper decrease is your Menkes disease. That's going to be having a kinky hair and the mental retardation in the patient. ठीक है ना? ड्रग क्या देते हैं हम वहाँ पे विल्सन में? ट्रायंटीन एंड पेंसिलमीन. तो कौन सा कैटरैक्ट दिखता है? विल्सन कैटरैक्ट. एंड केएफ रिंग्स, देयर इज अ कॉपर एक्यूमुलेशन इन द विच मेम्ब्रेन? बेसमेंट मेम्ब्रेन. ठीक है. देन वी हैव वन मोर, सीजीजी, फ्रेजाइल बड़ा है, अ पेशेंट विद इंटेलेक्चुअल डिसेबिलिटी विद बिग ईयर्स ऑन एग्जाम along with the gonadal enlargement. That is a which trinucleotide repeat? Fragile X. That's going to be a fragile X. So remember all the trinucleotides. Huntington disease, remember Huntington disease with a CAG, Friedreich ataxia with GAA, then myotonic dystrophy with CTG, and fragile X with CGG. Fragile X with CGG. Is that clear? Now the last case, let me accumulate all the stains. Let me write all the stains so you have a just fast recap. Chalo, then we have a yes, big fragile X, है ना? Patient with a intellectual disability with a big ears, okay, big gonads, that is going to be a CGG. Is that clear? Now tell me past stain. I will write fast bacho. Past stain, so for which condition? For glycogen. Past stain glycogen. Then tell me guys, Mason Fontana. Mason Fontana, that is for the melanin. That is for the melanin. Okay, then von Casa. Von Casa stain or alizarin red, both are for, my dear students, which condition? Calcium, depending minimum calcium or maximum calcium. All are for calcium. Okay, revise all the stains with me, whatever you know. Sir, Mason trichome stain. Mason trichome stain, that is for a collagen. Okay, von Casa alizarin red for calcium, Mason Fontana for melanin, past stain for glycogen. Okay, then you have one more, Pearl's blue, Prussian blue, for iron or hemosiderin. Then you have one more for reticulocytes. We have supravital stain. All the stains you remember, write down in the one supravital stain. You have reticulocytes. Okay, can you tell me about the fats? Yes, write it down. For the mast cells, we have toluidine blue. This is for which cells, bacho? Mast cells. Okay, for fungi, we have Gomery methamine silver stain, GMS stain. Okay, GMS stain for the fungi. Tell me what is the name of the stain for the fats? GMS stain, Gomery methamine silver stain, supravital stain, toluidine blue. Okay, then you have past stain, Mason Fontana. Okay, yes, Zeal Nansel stain for mycobacteria, Zn stain. Mycobacteria. Is that clear? Chalo. So this was all about the stains. Okay, oil red, Sudan black, lipids, fats. Fats and lipids, that's going to be your fats and lipids. Is that clear? Chalo. Alician blue for acid mucin. Chalo, likh do. Alician blue, acid mucin. Okay, chalo. Is that clear? So that is all about some important stains. Okay, so that completes our high yield topic discussion. Is that clear? Yes, I tried to cover all the main important topics. Okay. Now there are more important topics. I already discussed indirectly the cardiomyopathies. I discussed a bit from other parts as well. Apoptosis, necrosis ho gaya. So what you have to do, watch the particular video at the 3x speed, at a 2x speed, so that at least you will have a recap. vasculitis is very important, thyroid is very important, okay, hyperthyroidism going with the grades, hypo with the Hashimoto's, ठीक है ना, diabetes, rhodonine with the copper, very good, yes, rhodonine with the copper is an important one, write it down, rhodonine with the copper, okay, all the important ones. We have some more stains, but yes, these are the common ones. Copper, is that clear? Okay. So what you have to do is revise this session, okay. If you have any doubts, you go and ping me on the Telegram. Your doubt should be a study related, okay, and I'll be trying to answer as soon as the possible. Pediatrics will be after 2, 3, 4 days. I'll go with the pediatrics. We'll have a same session for high topics in the pediatrics as well. You can already watch the OB/GYN high discussion, and as well as we have discussed already the PSM, all the parts, okay. Pathology part 2, I think it's not possible, but yes, before ending this session, let's have a quick recap of all the things that we have studied in this session, okay. Let's have a quick recap of all the things that we have studied in this session, okay, and then we'll end the session. Is that clear to everyone? Yes. So let's begin. We started with the we started with the necrosis. It's an irreversible cell injury, okay. When it happens, hypoxia hota hai due to the ischemia. There is a ATP depletion and there is a stoppage of a sodium potassium ATPase pump. So we have a different types of necrosis. We have caseous coagulative necrosis, which is the most common type one. Sir, hypoxia is the reason. Sir, it's seen in all the organs except the CNS, and we have a tombstone appearance, infarct in the triangular pain area. Examples are MI. Liquefactive, brain में होता है, remember, brain abscess and the wet gangrene. Subtype of liquefactive is a fat necrosis, which is seen with the patients having any breast tissue disorder, omentum or the acute pancreatitis. Caseous कहाँ दिखती है? TB में and systemic fungal infections. Fibrinoid कहाँ दिखती है? MAP में malignant hypertension, rheumatic heart disease and polyarthritis nodosa. Apoptosis is a programmed cell death which is controlled by the genes. You have BCL2, BCLXL, L containing are the anti-apoptotic. Increased apoptosis P53 backs and back that goes with the pro-apoptotic genes. If we talk about a gel electrophoresis of the pattern, step ladder pattern goes with the apoptosis and smear pattern goes with the necrosis. Intrinsic pathways equation 9, caspase 9, extrinsic 8 and 9, executioner is caspase 3, 6 and 7. Then we talked about the calcification seen in dead and degenerated tissue is going to be your dystrophic calcification having a serum calcium normal levels. Metastatic में क्या होगा? Hypercalcemia होता है. Associations, you already remember tuberculosis, RHD, atherosclerosis, tumors, myositis ossificans, infections like CMV. Here thyroid related condition, parathyroid adenoma will be there, primary hypoparathyroidism will be there, CKD, increased phosphate will be there, Paget disease, sarcoidosis, multiple myeloma. Then papillary thyroid cancer, remember it's the most common type guys, seen in a young patient having a history of radiation exposure. BRAF is a gene and orphan nuclei multiple times or samoma bodies को याद रखना, ठीक है. And the spread that is seen is called as lymphatic spread. Then the gene mutated in the follicular carcinoma is going to be a RAS mutation. Follicular is the second most common type. Age is around 40 to 50. Earthly cells दिखती है and it's seen in a patient increased risk of having a long-standing goiter. उनमें दिखता है. RAS gene is the mutation. Serum thyroglobulin is the marker. FNA is not useful because it cannot differentiate adenoma with the carcinoma. That's why we go with the biopsy. After that, the cancer that arises from the parafollicular C cells is going to be your medullary thyroid cancer with a marker of a calcitonin. If calcitonin is negative, you go with the CEA. It is a cancer which shows the amyloidosis. Cardiomyopathy में restrictive को याद रखना. This one is going to be associated with a MEN2 syndrome. Anaplastic is the least common and having a worse prognosis. Patient will have a hoarseness of voice due to the RNA involved and the stridor due to the tracheal compression. उसके बाद intracellular accumulations, pigmentation, yellow and brown pigment is a lipofuscin seen in the heart and liver cells in the age. It's also called the wear and tear pigment or the aging pigment. Melanin में stain होगा Masson Fontana and it's a tyrosine derived pigment. Melanin absent होगा, patient को albinism होगा, patient will have a deficient of a hormone tyrosinase. Okay, and then hemosiderin is an iron derived pigment, okay, seen in the conditions having chronic iron overload like a multiple blood transfusions, thalassemia, and the stain is Prussian blue stain. Amyloid में Congo red stain दिखती है. Under the polarized microscope you have an apple green bifringence. Anthracosis is the most common exogenous pigment, black lung anthracotic pigment. Rheumatoid arthritis 7 होगा तो Kaplan syndrome बोलेंगे. Glycogen कहाँ पे दिखता है? Glycogen storage disease. The stain used is PAS stain. Then we have a giant cell arthritis. We discussed that it is affecting the aorta and it's a major branch. It's the most common vasculitis and superficial temporal artery is involved, and which is a branch of external carotid artery. Most common symptom is going to be headache, and most specific is going to be jaw claudication. Okay, on the biopsy we'll see a granuloma, and we'll see the reduction in the lumen sign because of the collection of the macrophage in the T cells. The spatial stain is Van Giesen's stain. Treatment is IV steroids. Alternative, you can give tocilizumab. Pulseless condition, Takayasu arthritis. In most common artery involved is a subclavian. It is having a poor prognosis. Coronary arteries on involved patient will have a MI. Renal activation of the RAS, predisposed to the renovascular hypertension, and sudden loss of vision, you have an ICA involvement. How to diagnose? CT angiogram, you will have a narrowing of the blood vessels, then you have a classification of the Takayasu arthritis. Complication can be aneurysm or the limb ischemia. Polyarthritis nodosa, we studied that it's seen in a young patient. It's having a type 3 hypersensitive reaction, and also which type of necrosis? Fibrinoid necrosis. Uske baad, we discussed that on the angiography there is a string of bead appearance along with the artery spasm. Yes, and there is erythematous nodules and ulcerations over the legs. Treatment is going to be high dose steroids along with the cyclophosphamide. And side effect for cyclophosphamide is going to be hemorrhagic cystitis, and the treatment for the following condition is going to be MESNA. After that, we discuss about a Kawasaki disease, and it's a mucocutaneous lymph node syndrome having a mnemonic of a crash. Conjunctivitis will be non-purulent, rash, cervical adenopathy, strawberry tongue, and the Palmer and plantar erythema with swelling, edema hoga. Okay, patient will have more than 5 days fever, and the cause of death is a cardiac. Then we have discussed these images as well. Treatment is IV immunoglobulin plus aspirin. Aspirin causes Ray's syndrome. The only condition in the kids that we give aspirin is going to be a Kawasaki's disease. Then the Berger's disease, also called as thromboangiitis obliterans, seen in the smokers. Other risk factors have already discussed. Arteries involved are the tibial and the radial artery. Claudication, intermittent claudication seen, and it associated with the Raynaud's phenomena having a color sequence change of WBR. Treatment for that is calcium channel blockers. Small vessels में Wegener's को याद रखना. Remember C and K in the Wegener's, strawberry gums, and cyclophosphamide is the treatment. Tried is renal, upper respiratory tract, and lower respiratory tract involvement. Then HSP, most common vasculitis in the pediatric age groups. Type 3 hypersensitivity reactions. Okay, there is a IgA deposition at the dermal papillae. Is that clear? And the platelet count is normal. It's a non-thrombocytic purpura. Bessett's oculo-oral genital syndrome having oral ulcers, genital ulcers, and uveitis and UV associated HLA-B5. Followed by that drug is infliximab. Then we discuss about the markers, calcitonin with medullary thyroid cancer, all these markers. That's what important. Okay. Then the graft allograft, two different individuals, auto, apna, iso, same identical, xeno from the other species. Rejections can be hyperacute, acute, and chronic depending upon the time. If it's immediate, acute, hyperacute, acute is weeks to months, chronic is months to years. Trinucleotide repeats, Huntington's CAG, Friedreich ataxia GAA, myotonic dystrophy CTG, and CGG Fragile X. The main important thing is the clinical symptoms over here in this picture. Remember, if they mention big ears along with the gonadal enlargement, Fragile X syndrome. Okay, abnormal body movements, family history, Huntington's chorea. Okay, loss of sensation in the feet and scoliosis, Friedreich ataxia, or off balance or failure to relax after shaking the hands, still shivering, it's going to be myotonic dystrophy. The cataract is Christmas tree cataract. Then the stains. So that's all for this session. I hope the session was much interactive enough. Thank you to all the students who have been interactive. All the best. Don't compare yourself with anyone. You're best. You have studied all these 5 months. Okay, now put the rest to God. Okay, is that clear? Now don't compare your knowledge with anyone. Right now you might feel that you are nervous, you are anxious, you have not studied, you are not able to recall. I will read this file, I will do that and all. But trust me guys, I'm myself a foreign graduate, so I know I can feel you guys. But yes, you really can do it. You got this, and I wish you guys all the best. Okay, always here, no matter what, remember one thing, we never lose. We either win or we learn. या तो सीखते हैं या तो जीतते हैं, right? So don't worry about anything. Whatever will be the results, you give your best shot. You give your best shot. Okay, don't change your answers. Okay, and thank you all for your good comments. Okay, revise the same session. I'll be back with the pediatrics soon. We'll have a pediatric discussion as well. We'll try to recall all the important topics. Okay, चलो ठीक है. Keep solving MCQs, do PYQs and PYTs at this time, because if you go with the new questions, नया देखोगे तो you will be stressed that this is not there, this is not there, this is not there, because medical knowledge is very vast. You go deeper, you cannot find an end. You can go deeper, but वहाँ पे superficial भी पूछेगा, deep भी पूछेगा, but at least 150 questions ऐसे होंगे that if you have studied for the 4 to 5 months अच्छे से, you will do it. Okay, surgery, I think Dr. Maruti will take. Okay, thank you all of you guys. Okay, I'm waiting for you guys to welcome onto this side. Okay, you all will be as soon doctors, inshallah. So till then, revise the stuff. Goodbye, good luck, Allah Hafiz, all the best, all the best.